We are in an interesting place in class. We are actually a little bit ahead. Next week is going to be a guest lecturer. Mike is going to come in. He's one of our instructors at NETS, and he's going to do OB and emergency childbirth. But tonight, what I'm going to do is I'm going to start off with something a little bit different. I'm going to use a website called Mentimeter. So if you guys haven't used that before, it's going to allow you to join a room. You'll enter a code in, and then we can all kind of see what these the answers are and some of that kind of topics. So we're going to start with that, and then we're going to get into some review, I think, on some of the things that you guys have wanted to review a little bit more. And I'm also going to talk about some other stuff that's happening in specifically Vermont EMS. So as I share my screen here, you guys should be able to see the first question, and you can just open up another browser on your computer, or you can use your cell phone, go to menti.com, and you can type in that code, and then we'll all be able to answer and do this. It is anonymous, so this is not a true pop quiz. I'm not you're not going to get a grade or anything like that. We'll talk about it, and it's really just so you can get a sense of where you're at, and I can also get a little sense of that. So go ahead and just log into this room, and whenever you get there, go ahead and answer.
Oh, Kevin, where's the link?
So just go to menti.com. You can also put the link in the chat if you would like.
Oh, sorry.
No worries. I can figure out how to see my chat. Do have something like 40 people in the class, so I'll give it a little bit of time here. It does, Max?
Silly question. Where is the question?
What do you mean?
All it's showing on my screen are the answers. There's no question.
Well, the question is, a pop quiz activates. That's like that big top thing. Took me a second to figure it out too.
Yeah, that's the question.
Okay,
so what part of the body is the act of getting a pop quiz activating? Yeah, just a couple more seconds here, guys, and then we'll talk about it. All right, so the answer that I'm looking for here is the sympathetic nervous system. So that frontal lobe, which is the second biggest answer that's coming up here, that is part of the brain that's really kind of orienting our thinking and that kind of side of it, our personality. So the sympathetic nervous system, that's the section of our brain that responds instantaneously to what we experience. So if it's a pop quiz, you're not prepared for it, you might have a little bit of anxiety around that, right? It's going to amplify your adrenaline. You're going to get some adrenaline. You're going to get a little bit of a sympathetic nervous system response. Well, you might be using your frontal lobe to consider and think about the answers of a pop quiz. That's not the immediate activates, right? Anyone know what the islet of Langerhans is? I put that in as a little fun term. It is one answer. It's a part on our pancreas that plays a key part in the Yeah, it is in the pancreas, and it has to do, or it helps along with diabetes, or not specifically diabetes, but it helps along with blood sugar. Here's the next question. All right, this one's kind of running away with it. That is the correct answer. Yes, to reduce pain due to cardiac compromise. The trick being here is nitroglycerin is given by an EMT, right? Anything that is not within the EMT scope of practice is not why we're giving that medication. So we are not giving it to treat a heart attack. We're giving it to reduce the pain caused by that heart attack. We're not giving it to lower blood pressure. We're giving it for its vasodilation effects, which is going to help expand around that clot, potentially get some more blood flow to the heart. We're not actually giving it to lower that person's blood pressure. Next one. This one should be a little extra on your screens here. This is the main question, and then there's going to be a little bit of a prompt on your screen. All right. So this one, we got answers in every single potential. Why is hypothermia the biggest one running away here?
Because they were in the
Because they would have
shower.
lost
for
their
a few
body heat.
days.
Yeah. Yep.
I'm assuming
that's what-
water's still running. So it's
Potentially.
probably cold by now.
Right. If they've been in the shower for 2 days, even if the water wasn't running, right, they likely don't have any clothes on. They have no way of preserving their heat. Bathtubs are that kind of porcelain material most of the time, right? So they don't retain heat very well. If they were laying in there for a couple days, they will likely be suffering from hypothermia. Now, we can't rule out the other things. It is a potential for there to be heat stroke, right? I said it's a hot day, but that doesn't necessarily matter, right? The surrounding temperature of the environment doesn't necessarily mean that they won't be hypothermic if it is above freezing. And then hyperglycemia, not really anything in how they present, which should be on that thing, right? I think I said pale, confused. That isn't how we see hyperglycemia present. They're going to be hot, flushed, maybe confused, but they won't have that same kind of a response. And then stroke, yeah, we want to rule that out. So we do an assessment, but for the most part, we're likely going to be seeing hypothermia in this situation. Good job. All right, a couple more. Good. I thought I could sneak this one by you guys. Yep, always assess for scene safety and apply our appropriate PPE. That is the first thing we are always going to do, regardless of how crazy the situation looks in front of us, right? It's going to take 2 seconds to do in our heads, but we do have to say it out loud for our tests. You know, it is arguable we could call a paramedic on our way. That's not a bad thing to do. However, when we arrive on scene, that's really our first priority. No matter how many patients are there and no matter what's going on, we need to assure that we are not going to become one of them. And that when we're engaging with them, we want to make sure that we're protecting them as well as us. So good. Last quizzy one here. Oh, it's neck and neck. Looks like CMS is pulling away. All right. Which one is it? What do we do first? First,
If you manually
manually stabilize. Yes.
if you manually stabilize, you'd have to check CSMTs again after the.
No.
Okay.
Nope. Nope. Because we only check CMSs before we apply any splinting equipment and afterwards. Our hands are not splinting equipment. We have the ability over how hard we push down and all that kind of stuff. Remember, the reason we're checking those CMSs is to make sure, one, initially, are they there? How severe is the injury? But also, if we apply a splint to it and we check to see if the CMSs are there and they're not, we have likely applied the splint in a way or adjusted their arm in a way that is messing up their circulation. So manual stabilization, that is just us protecting it or having the patient do it. So anytime we see a broken injury or somebody has a suspected fracture and we're going to consider splinting it, if you look at the skill sheet, the first thing after scene safety BSI is manually stabilizing that extremity. Just like how if we're taking C-spine precautions, the first thing we do after scene safety BSI and scene size up is manually stabilize that head. Because if that patient with a broken arm, you come from behind them and they turn around and they flip their arm around, they don't know what's going on, you're likely causing more injury. So the first thing is, hey, always keep that arm right where it is, okay? Manually stabilize it for me. Then I'm going to assess your CMSs or PCSMTs, okay? So the next thing we want to do right after stabilizing it is those PCSMTs, those CMSs. We splint, then we check again, and that would be golden, okay? But we always want to make sure it doesn't go anywhere first. All right, these next ones are just a little bit more about how you're doing. Again, completely anonymous, so just slide with how you guys are feeling. It's going to give a random kind of deal. How confident are you feeling with stuff so far in class? Please be completely honest.
You combine medical and trauma assessments, and those are very different, I think, with this. I would speak for myself, but I imagine for lots of us.
Sure. Yeah,
I'd
I was
agree.
more so trying to combine practical assessments versus skills, but I completely understand.
Kevin, I do have a question about the actual psychomotor testing as far
Sure.
as the airway, if you don't mind.
Yeah.
So are we going to be tested on suctioning?
Yes. So in that BVM station, so you're going to set up your oxygen tank. That's one whole station. In another one with the BVM airway placement. It's going to work how you come in. They'll tell you you have an unresponsive person. You'll assess their airway, breathing, and circulation. Their airway will have secretions and vomitus in it. You'll suction, and then you will have to place an airway, begin bagging, attach it to oxygen, and then proceed to ventilate that mannequin at an appropriate rate. So it's combined in one station. You're not going to have a specific station on it.
Okay, so that goes what you said it was BVM and airway management. That's considered one station.
Yep, you'll have some set stations, and that's another thing I wanted to talk about after this. I was going to give you guys some resources for it. But thank you for answering on this one. That's really good information for me to have. And then the last one here is more so, what do you want to learn or review about most? We do have some set lectures coming up. We're going to have OB and emergency childbirth. We're going to have operations and other EMS kind of background stuff. And then we're kind of wrapping up with our lectures, and we're going to move more into review. We only have a couple labs left, so that's a good couple months still, but we only really have maybe 2 or 3 in-person times together left. So what do you feel like you need to review the most? What do you want to learn? What do you feel like you haven't learned enough about? Whatever. All right. Thank you, guys. Don't stop responding into that. I'm just going to close out so that not everyone needs to read all these. I'm going to go back and read through them and see what I can do to help you guys out here. Good news for you is reading through just kind of a general idea of what you guys wrote down here. That's a lot of what I was going to talk about tonight. We are going to review a couple different things, including pharmacology. But before we do that, I just want to review some things with you guys, or to show you some resources here. So the first thing I just want you to know is, if you haven't already, these EMT trauma, or these assessment sheets, the NREMT sheets, are online. You can find PDF versions of them. You can just Google it, or not that one. I just can't see my whole screen here. Come on, go away. Or they are in Jones and Bartlett under resources. They are PDFs right in here. You can look at those whenever you need or feel like you do. And these are the ones that will be on your test. So you can just download them. That's what your test is going to consist of. So the NREMT test is one of those, is the only test that I know of where they give you all of the answers for the practical test before you test. And that's one of the reasons why they're never going to tell you what you failed. If you fail anything, it's because you had all the answers from the get-go. That's kind of their rationale. So go ahead, use whenever you need. That's a great place to start just getting down what you're going to have to do. We are going to continually practice with them. If you've been tested on a skill in class with the iPads and stuff, these are essentially what we are using. We are using NREMT standards and doing it in a very similar way. Now, some of the skills that we do on the iPads don't have skill sheets like this because there isn't a set station for you at your exam, but these are the things that will be on your practical exam. You will definitely have medical, trauma, airway and BVM, CPR, and oxygen. And then you will have a random selected on that day, which is either going to be joint or long bone immobilization or bleeding control. So you do have to be familiar and comfortable with all of these, but you will not be tested on every single one on the day.
Kevin, can you just repeat those, please?
Absolutely. So you've got medical, trauma, airway and BVM, oxygen administration, CPR, and you will have a random station, which is going to be between joint immobilization, long bone, splinting, or bleeding control. Pray for bleeding control. It is very easy, takes 2 minutes. But that's just for the practical exam. However you feel most comfortable studying for this, that is going to kind of be up to you. There are many different ways for people to study practical things, right? This is a practical test. This is essentially performing a set skill, a set of motions correctly in correct order, making sure that your evaluator is doing that. For me, I always just kind of felt that this was really straightforward. That's just kind of how I saw these practical things, was that I've got these written thing out right here. If you read the student sheet, it tells you what the evaluator should be looking for. These are the same sheets that your evaluators use on the day. And so if there's a sheet like BVM that has the place where your evaluator is supposed to speak, use that as like a divider of what you're supposed to do, right? So you come on to the start, you say scene safety BSI with your jazz hands. You'll check responsiveness. They'll tell you all about it. You request additional help and you do ABCs. After you do that, this says, note, after checking responsiveness, then checking breathing for no more than 10 seconds, the examiner should inform the candidate the patient is unresponsive, apneic, and has a weak pulse of 60. Which then afterwards, you will open the airway and I will say, hey, there's vomitus and secretions in there. Guess what? Then you start to suction, right? So if you look at these sheets and you kind of understand the flow of how they're supposed to go, that is really kind of the best way that I was able to internalize what was going on here. Not every single one is going to be like this. Some of these sheets don't have exactly what the evaluator is going to say, like trauma and medical. It's going to be per the different scenario. But one of the things I kind of tell people when they're preparing for the basic EMT practical and the written is, if you break it down, if you look at it, the NREMT, they don't trust basic EMTs very much. Okay, so there's a whole bunch of things that the realm of EMS kind of encompasses, but that's why they divide it up so much, right? So you guys are getting the training and the knowledge just enough up to a certain part where the NREMT in the state of Vermont feels comfortable. That's all they're going to test you on. And that means in the medical assessment, they're not going to throw something that you can't help with at you. You're not going to show up as a basic EMT and they're going to send you like a hyperkalemia call because there's nothing that we can really do for that. They're going to give you a scenario which you can help. So they're going to give you difficulty breathing because you could either give epinephrine or albuterol. They're going to give you chest pain because you can either give nitro and aspirin, and they want to assess whether or not you're going to take a 12 lead. Or they might even give you like a hypoglycemia because you can give somebody oral glucose, right? So if you're thinking about it that way, they're testing you on what you would be able to do. They're never going to give you something that is out of that realm. So just worry about that. And that's what really helped me with the practical exam. Now, when we start talking about the written, this is a little bit more of a challenging topic. The NREMT, again, doesn't trust us very much, which is totally fine. I don't trust people very much too. But that means when it comes to reviewing for their exams, they don't send out any practice test questions at all, right? So the only way that we have to practice written test questions based off of NREMT stuff is to use services from people who have passed the exams and have an idea about how the NREMT sets up their questions. So those mentee questions that you answered earlier, I was doing a little bit of a job of trying to make them similar to the NREMT. A lot of those questions you answered, I had in different forms on the NREMT exam. That 10-car MVC one, it was on there. And it was far more extensive. It said you have like 13 patients. One woman is on the side of the road. She's 9 months pregnant and she is feeling contractions. There's a guy on the other side who is missing an arm. And there's a man down the road with an avulsed scrotum. What is your first step? And all those answers were on there, and scene safety BSI was in there. So they will do that. Same thing with like medications. Right, they're gonna ask you what medication is a platelet aggregator inhibitor. Right, they're not going to ask you which medication makes a platelets more slippery, which you might be like, oh, aspirin, right? I know that one, but they're not going to ask it in that way. So it's tough to recommend a practice service because, from what I have found, due to how kind of closed off the NREMT is that any practice service you use, kind of including the ones that we use, have a degree of error to them. There's some questions, like because these are put out by different groups, by different people, there are some questions that have bias behind them, or whatever, it benefits them in some way. So the one that I use, and I have never really had a major problem with, is EMT National Training. They have a little bit of free practice stuff for you here. So I'm on this page right here. So you just select EMT up to paramedic, and you can create flashcards based off of different categories, or you can do a simulation exam, which is 70 questions and you have 2 hours, and it's adaptive, similar to how your exam is going to be through the National Registry. You can buy a subscription to this service for a couple months and get like unlimited things. If that is something you wanted to do, this is the site that I feel most comfortable recommending. However, again, through my time of taking these practice exams, there have been a bunch of questions that are kind of iffy. Like there was one that I can remember when I was studying for my test for advanced EMT recently, that was like, if you note that you're pumping or you're BVMing someone and you notice that they're getting gastric distension, as in we're pumping their stomach full of air, what's the appropriate thing to do? What we do is adjust the airway, auscultate for lung sounds, adjust how we're doing, maybe insert an airway, right? What this told me was roll them onto their side and then start massaging their abdomen and like patting their back so that they burp. And I was like, what? And in the rationale, it said, this is a debated upon treatment in EMS. This one published journal says that it's great, but these 300 other ones say don't do it. But we are a subservient of this published journal, so we recommend it. If you ever seen it, that's just ignore that kind of stuff. When I finished using it, I wrote to them and I was like, that's a bad question. But this is the best one that I have personally found. So if you want to study and practice for what the registry exam is going to be like, this is another really great, not great, but it's the best one that I've found. This is the one that I use.
And to clarify one more time, I'm sure we've answered it 100 times. The practical exam is following Vermont standards and the written part is national standards, right?
Yes. Simple answer, yes. If you use Vermont protocol in the practical exam, you will be fine as long as you are testing in Vermont. Because we're around Vermont providers, they know that if you're using that, you've been trained to act appropriately as the state would tell you to. And then, yes, because the written exam is solely based off of NREMT, it has to be that protocol. If you use NREMT protocol during your practical test, you will be fine. It's whatever one that you feel most comfortable with. I always recommend, while you are still not certified, go by the National Registry, because then it's going to give you less confusing things in the tests. And then afterwards, when you join the service, let them mold your mind to Vermont. That's just how I do it. Now, as I say that, let's talk about Vermont protocols. I just wanted to review this with you guys because they actually released those new protocols, and there's some changes in it. So I thought we could just take this time, Not trying to kill time or anything, but go over some of the changes. Essentially, I didn't see anything that was like huge for you guys. What I saw, blah, blah, blah. One of the big ones that they changed is they took away the emphasis for COPD on meeting a lower criteria of SBO2. Let's see if I can find that. Where'd it go? I liked the wording of it, and I thought you guys would appreciate. Where'd it go? Oh, it was on the first page right here. Removed EMT. Right, removed 80 to 8 to 92% in COPD, and they admit too confusing. Patients in respiratory distress, it's more important to give adequate oxygen that they can tolerate for 911 transport times. So essentially, that tells us to stop worrying about giving oxygen to COPD patients as frequently. If they're having severe difficulty breathing, even if they have COPD, they should get some good oxygen. Other things are they rewrote the behavioral emergency protocol from the ground up. So they added language to guide us and to help practitioners with suicidal ideation refuses. So added resources like calling for crisis help and using the police and mobile, like that kind of stuff. So they rewrote that protocol to make it a little bit more streamlined for us. There wasn't much added to you guys. The one thing that is kind of cool, I've been hearing about this recently, but we have a new treatment for nausea, and you can allow patients to inhale the vapor from a alcohol cleaning strip, an isopropyl wipe, 3 times every 15 minutes as they tolerate, because that helps with nausea. That is now in your protocol. So if someone's feeling really nauseous, take out one of those little strips, have them hold it by their nose and have them take like 3 small breaths, put it away, do it again in 15 minutes if they want. That's a treatment we have for nausea. Just a cool little thing there. The things that were changed for advanced EMTs, we can give IV acetaminophen now, and we can do a new IO site. We drill into the femur instead of the tibia, which is kind of cool. But yeah, that's pretty much it as far as I have seen. So good news for you guys, you're not going to have to like relearn much of anything. There hasn't been any huge changes, just a couple little additions on things that you guys can do. All right. Any questions so far? Is what I'm saying to you guys helping / making sense? The protocols are changed every 2 years. Or they're reevaluated every 2 years. And for the most part, there are just little changes, unless there's something big that came out. Like the biggest one that I can remember was the change from backboarding to spinal motion restriction. That was a pretty like, just job changing kind of deal. The things that we did day to day changed a lot. Any other questions about Enter EMT stuff? Good. If you have any questions, please do not hesitate to send Chris or I an email. Really start reviewing those sheets. And for these next couple labs, guys, we're pretty much going to be focusing solely on those skills, getting you guys comfortable with doing them. And then also we're going to do scenarios because 1, we want you to pass the test, but we also want you to be prepared for the real world so that you can actually be a very good provider. That's what we want.
So is that EMT practice under the EMT prep app? Does it say that on top?
The EMT prep app.
Yeah. Does it say
I don't-
that on for practice?
I'm not familiar with the EMT. Did you buy or like download the app for that
No,
website?
I looked up the EMT practice and I saw one thing that said prep on it.
Yeah, so it's EMT
testing.
national training, and then you can just follow the links in there to like EMT, and then they have like test prep, and then there's at the very bottom there's the EMT simulation exam. That one's just as close as you can get to like the written.
All right, thanks.
Yep, sure thing. Okay, so what I have in a PowerPoint here, and I can jump around to whatever you guys want. That's kind of what I wanted for tonight. I do have some set things I was going to review with you, which were kind of confirmed based off what you guys said in that Menti. I was going to go over the last bit of trauma, and then also we're going to review pharmacology. We can talk about that all you want. And then I was also thinking we could review some CPR and that kind of stuff. But seriously, ask questions. This class is going to be driven by what you guys want to know most. We've covered all of this stuff already. So delve deep, ask questions. This is really for you guys. So what I have here, right, we're going to talk about shock first. So again, avoiding the ideas that are kind of given to us by media, like Grey's Anatomy. There's a difference between having emotional reaction to something and going into what we call hypoperfusion, which is a life threat and something that kills a lot of people due to injury. So you can have a strong emotional or psychological response to something, which we do call psychogenic shock, but it's not the same thing. It's not system-wide hypoperfusion. So in that sense, what we'd be considering there is something along the lines of syncope or fainting. And this is a real reaction that the body has. If there is a shocking event to it or something that like triggers a quick emotional response, we can have an upset where essentially our brainstem malfunctions and we get a really quick vasodilation. Our blood pressure drops pretty quickly and we lose consciousness. Happens all the time. Not really anything to be worried about, especially a lot of times it happens after standing up too quickly, forgetting to breathe for a little bit. If you're distracted, that can definitely happen. Really, a lot of people have fainted in their lives, myself included. So this is not shock. This is a quick reaction from the body, a quick dilation, but we return to normal relatively soon. Whereas hypoperfusion, this shock is system-wide body failure, right? Caused by a multitude of different reasons, but it is a failure of the systems of the body. Now, one of the things that's a little bit confusing is that when we're talking about shock, right? If I was to ask what is the main sign of shock, a lot of people would probably say like trending down blood pressure, lower blood pressure, high pulse. Unfortunately, that's not the sign of shock. That's the sign of decompensated shock. So if we see vital signs that are reflecting that this person is going to die, we're seeing these low vital signs. Like whenever you've done a trauma assessment and you say, I want my partner to take that full set of vital signs, you get something along the lines of blood pressure 90/60, pulse rate is 144, weak and thready. Their respiratory rate is either 3 or like 40, right? All of those signs, all of those vital signs tell us that this person is decompensating and they're going to die very soon. If we arrive on scene after a major trauma or an issue like a highly suspicious incident, and we see somebody who's injured, but their blood pressure is 120/80, their pulse is between 80 and 120, the respiratory rate is 12, but they're anxious, they're scared, they don't know what happened, they lost a lot of blood. What we are seeing is that compensated shock. So they are in shock, but their vital signs will not reflect it because our body is really good at making us think or holding us over until we can get help, essentially, until we can stop what's happening. So as soon as this guy right here is losing all that blood, yeah, he's frowning, right? But his body's going to compensate, at least for a little bit. He is losing quite a bit of blood, but his vessels are going to tighten. so that his blood pressure stays relatively the same. You know, he might have a little bit of an elevated pulse, maybe a little bit faster breathing to get more oxygen around, fill up whatever blood he has left. But essentially, we're not going to see anything so far out of the realm of ordinary that we would think that somebody is in shock. So when we're treating for shock, we're really trying to predict it or stop it from getting as bad as it's happening. So if you think that somebody would be going into shock, if you looked at somebody and said, wow, that was a bad accident, or wow, you're having a heart attack, right? But their vital signs are relatively stable, start treating them for shock now. That's kind of the purpose, because it will only get worse if we don't do anything about it. And we don't want to wait for that to happen. So again, shock can be caused by a multitude of different things. So we kind of have this chart, which is one of the more common ways to think about it. So in the center, we have shock, hypoperfusion, just in general. And then off of it, we have the different kind of categories. And it has been expanded. There are different ones that you can see similar to this that are just a little bit more broken out. But for our purposes, what we can assess and what we can really figure out about our patient, this is kind of the best one for us. So if we're talking about that hypovolemic, low fluid, essentially, doesn't necessarily mean low blood volume, right? That's when we would see hypovolemic shock. So it could be due to them bleeding a whole bunch, or it could not have anything to do with bleeding and something along burns, right? Like we lose a lot of our fluid that way because we're not able to retain it through our skin when the top of our skin is gone. Another one that could be an issue here, right, is like somebody who's super dehydrated. We see this sometimes in infants and kids. If they have, like a GI upset where they're throwing up or having diarrhea constantly, they're about this big, right? They don't have a lot of fluid. And if they're throwing everything up and they can't retain anything, we can actually see infants go into hypovolemic shock because they haven't actually had any fluid. So it can also be that way. When it comes to things like cardiogenic, those are pretty straightforward, right? If it's CHF, if it's a heart attack, if they had like a congenial dysfunction with their heart, if they had an injury, if they took too many beta blockers or calcium channel blockers, if they did something that could lead to an issue with the heart not getting blood everywhere. Of course, we've got like metabolic and respiratory, they're not breathing. Obstructive, something is actually stopping the blood from working. So, or stopping the blood from getting perfusion that it needs. So if they don't have any oxygen getting into their system, if it's a pulmonary embolism blocking off the lobes of their lung, they're not getting any oxygen. Same thing with the tension pneumothorax, that kind of stuff. Same thing with distributive. This is when something in the body's system of getting things out there goes wrong. So like sepsis, the whole entire blood system is corrupt. It's essentially infected. Neurogenic is when like the brain stops working enough to do those functions. And anaphylactic is because the body is essentially messing up when it has a response to that allergen. So those three stages, very important, because for the most part, when we do our trauma exams, you are going to have people who are, who are decompensating. You're going to get there and you're going to say, wow, they're decompensating. This person's going to die. And that's normal for a trauma assessment. Like I say this all the time, but if you get there and you're doing your trauma assessment and you're kind of like, oh, you know what? This isn't as bad as I thought, right? We could probably take an ICZ ride up to the hospital, give them an NRB, 8 liters maybe, just kind of hang out. Maybe they'll give a report up on the way. No, you're missing something if you think that's with an NREMT trauma exam, right? They will always be severe. They will always need treatment and interventions. So if the body's doing its job right, we really will have to work hard to assess to see if somebody is in compensated shock. It is really more of an idea of what happened to them, what is a potential injury that they could have gotten from this, like what amount of force did they encounter, and how worried am I, right? They could have internal bleeding. They could have an internal brain bleed that we haven't seen, right? Or that we haven't seen signs and symptoms of. There are plenty of things that could be happening. If you stack on those what ifs, you'll just keep going. But essentially, if you look what happened to them, is it severe enough where they could have like an injury that kills them? We should probably treat them for shock because we can't be sure. And if they start to decline, it's very quickly that they're going to get to the irreversible stage. So some of the things you might see. Now, this isn't all encompassing for everybody, right? They might have a weak pulse, specifically in the distal areas, right? As soon as somebody goes into like fight or flight, our body shunts majority of our blood away from our extremities back into our core to supply our brain, our eyes, our heart, all of the really life-keeping organs. So even if somebody's having like a seizure or is post-ictal, if you went right to check their distal pulse, you likely won't feel anything. So that might lead you to think, oh, wow, they're in cardiac arrest. But if you felt they're carotid, you'll feel a nice, strong thumping pulse. Okay. So they could have a weak pulse, but we also want to make sure that if they're really severe, we check to see how strong it is close to their heart. If it's out here and it's weak, that's pretty potentially standard. But if it's really weak in the carotid area, that's really bad. The biggest kind of common ones that we see is people are going to be anxious and restless. Even if they're not aware of an injury that they have, their body is. And so they might have those sensations. They might have that feeling of anxiety. They might be kind of unable to sit still. They don't know what's going on. They're still amped up. Their body is telling them they need to get out of there. They need to get some help. Another one that we kind of see in people who are really starting to decompensate is a feeling of impending doom. Now, this is another thing that is pretty common when it comes to heart attacks, is that if your patient is having kind of a severe issue or they're feeling kind of iffy and they look at you and say, hey, I feel like I'm going to die. Am I going to die? Take that seriously. Because if they have a heart attack or if they have an injury, this is a legit assessment finding, is a feeling of impending doom. And if they are really feeling it and they're not just kind of saying that, like I've gone to multiple people who've eaten a whole pot brownie and they look at me and say, I'm going to die. And I say, no, you're not. Right? You just had a pot brownie. But somebody who's having a STEMI and I see that on the EKG, they look at me and say, hey, I feel like I'm going to die. Am I going to die? I'm going to say, you know what? I'm going to do my best to make that not happen. Hey, driver, let's get going really fast. So that is a legit sign. Altered mental status is going to be more along that line of the agitation and anxiety that might be confused. We're also going to start to see the pallor and clammy skin. It's not going to be like super, super pale and sweaty like they would be in decompensated, but it's heading that way. They're going to lose some of their pigment because we're not getting enough of the nutrients we need. They could be breathing shallowly. That's kind of mimicking when we have those really that anxiety, right? They could have a feeling of shortness of breath because they're not getting enough oxygen throughout their system. Sure, they are breathing, but remember, hypoperfusion means that they're not getting that oxygen around. So even if air is going in and out of their lungs, that metabolic system of that oxygen actually getting into their blood is failing. So that can cause that shortness of breath. Marked thirst, that just means that they're really thirsty. They want something to drink, just a sign that their body needs fluids. They could be nausea or vomiting, and they could also have a delayed capillary refill. That is just the capillary refill, right? That is just a measure of circulation to the most distal part. So if that's reduced, they are going into hypoperfusion. Now, when they start entering that decompensated area or that stage, that's when we start to see the things that you will see in your trauma exams. So their blood pressure being really bad, really low. A terrible breathing pattern. So whether or not it's super fast and shallow, like, or super slow and shallow or barely moving, right? You don't see good chest rise. You just kind of see a little bit. You might be able to feel like a little bit of heat coming off of their mouth. Thready or absent pulse. Thready means like you can't necessarily feel it all the time. It feels super weak. It's in and out. And then dilated pupils that are slow to respond. That's also another really big sign that they are decompensating. A lot of times decompensating just means really bad. If we can treat our patient as soon as we can, the risk of them going into decompensated shock lessens. It's not going to completely go away, right? We can't do that. They need a surgeon. They need blood infusions. We can't do any of that. We can just get them there with airway management. So that's what we're doing. We're trying to prevent decompensated shock. And unfortunately, if we start treating shock at decompensated shock, our chances of getting them out of it pretty low. and they will tend to go into irreversible shock. So that's why when we're talking about these types of patients, there is that idea of the golden hour, right? If we can get this person to the hospital within an hour of the time like the incident happened, that's best possible case scenario. For the most part, it happens, but like a lot of I'm sure you work out in the rural areas of the state, there are very rough times getting people to a hospital within an hour. That could be really bad. You might need to call a helicopter. So our idea here is we want to hold off decompensating and irreversible shock as long as we can. So that's why we're treating them for shock. We are not treating their shock, right? We're making sure that it doesn't get any worse. We're trying to keep them at baseline. We're trying to support all of their body functions that they need to stave off this irreversible shock. So that's why we want to reduce all bleeding or stop any chances of them leaking out that red gold, that blood. We want to position them in a way that makes their heart not have to work as hard. If you're standing up straight like I am, my heart has to work a little bit harder to pump the blood up and down, fight it back, right? Because of gravity. If we lay somebody flat down, their heart evens out a little bit. It doesn't have to work as hard. It just circulates things on the ground. We're using gravity to our advantage. We want to keep them on high flow oxygen because simply shock means not enough oxygen perfusing through the body. So if we can get them high flow, if they are breathing a little bit on their own already, great, they can get that oxygen in. If they aren't, we will breathe for them. We will keep them as warm as possible because we use a ton of energy all the time at keeping ourselves warm. That's like majority of what our body's work is on a day-to-day basis, is just keeping us warm. And we'll turn up the heat. And if they're conscious, right, we're going to provide PFA. We're going to talk them through it. We can explain exactly what we're doing, right? We don't really want to shy away from telling patients what we're doing because that kind of makes them not like us, right? If you were injured, you were feeling like you're going to die, you were in a bad situation, you just bled a lot, and your EMT, you're like, what are you doing? And your EMT's like, stuff, oh, I'm just, blah, blah, blah. Like, you don't need to know, you're a layperson, right? No. Hey, I'm doing this because I'm worried that your body is not getting enough oxygen. I'm trying to prevent it from working super hard, right? Be honest with your patients. Tell them what you're doing. I'm treating you for shock. I'm doing things to preserve your body heat. I'm giving you some oxygen, right? And I'm keeping you flat so your heart doesn't have to work as hard, right? This is going to help you. Now, we've talked about the Glasgow Coma Scale. Our opinion on it has not changed. It's nice to have in your brain, right? Like if somebody says, what are the main components of Glasgow Coma Scale? And you can say, well, the GCS stands for the Glasgow Coma Scale and the total is 15. The lowest you can get is 3. They'll probably be like, yeah, you know about it. You're good. This is really just, it's an ideal. It's one of those things where we'd say, this would be nice if we could just say one thing to tell the providers far away how our patient is doing. Like if I was just able to say, yeah, my patient is 10, not age, but like they have a rating of 10 and you were able to exactly understand how they're doing, that would be great. This was that idea. It doesn't work that way. You can have a whole bunch of different combinations of all very similar numbers that end up being different patients. So this is more so just an idea. If we look at it and we just say, we look at our patient, we say, hey, and they don't open their eyes and look at us, or they don't respond to pain, that is just supposed to tell us bad, right? They are doing poorly. But if they're able to open their eyes, they're able to
I just
Oh,
respond
asked
to
Adam
us.
to bring me over chicken Alfredo.
Chicken Alfredo sounds great.
Sorry.
No worries. So if they're able to look at us and they know exactly what's going on, yeah, awesome, cool. But if they don't say anything to us and they don't respond, that's bad, right? All of these assessments are just leading us towards either, okay, is our patient all right? Can we stay and play a little bit? Or is it bad? Do we need to go? And that's essentially all this is. So even though this next slide says when we're communicating with the hospital and stuff, we want to include a GCS if it's less than 8, that's one of those things that if we have a good report, we don't have to calculate. So we're going to use this a lot. We are not the people who get on the phone to the hospital and say, I am calling a red trauma alert, or I am calling a STEMI alert. I am calling a sepsis alert. No, we are not the people who call the alerts. We give the hospital the information about our patient. And if we know what the alerts entail, we tell them what they need to know so that they can just say, great, we're going to call an alert, and they do it. If you call the hospital, don't give them any report about your patient, but just say, I'm calling a red trauma, and they took your word for it. If they took all the EMS providers' word for it, there would be so many false trauma alerts called. So the whole purpose is the hospital knows their protocols. We know our protocols. We know our patients. So that's the whole point. Give them a good report about what is happening to your patient. Don't tell them what to do. Okay, I had a conversation with at a service when we were doing a training about this. One of the people was kind of upset because in the protocol it says call the hospital and give findings and report for like a stroke alert or something like that. But no, we are not those people. We are not the doctors. We just report what we have. And then if it meets the criteria, that's when something will be done about it. So if we do have a trauma patient who has hypotension or respiratory compromise and maybe a penetrating injury to the chest, they are immediately just going to say, good, thank you. How long are you going to be? And we'll say 10 minutes. They hang up. They're going to call a red trauma. We focus on taking care of our patient. Now, if they didn't have these things, right, they just had hypotension and they had a finger cut off, and we say, call a red trauma. They got hypotension and an amputation, right? The hospital is going to say, read me the protocol. Could you get me a GCS? Do they have respiratory compromise? They're going to go through it. But if you just tell them what's happening with your patient, they'll know. They won't have to ask questions. So here's that protocol. This isn't the new one, but I don't think this has changed at all. This is what the hospital uses to determine a red or green trauma. So if you know what this entails and you know that your patient meets it, just tell them what you found on here. You can also say like, hey, my patient has this, this, and this. You know, from what I know, they meet the criteria for a red trauma, but we're never going to tell the hospital that they should call it. They are going to make that decision. So some of those things that are going to just spark our nervousness or a suspicion of injury right away are just things that, and this is kind of the more common list of things. So motor vehicle crashes, right? Cars are very heavy, they go very fast, and they kill a lot of people every year. Same thing with cars versus people, right? That also happens, and unfortunately, those pedestrians are far worse off than the cars usually are. And the interesting thing about cars, in the past couple years, you know, with safety mechanisms coming out that are more and more effective, it's actually interesting. I was talking with another instructor about this, and we were mentioning how with car accidents, you tend to see people being pretty okay with minor injuries or very much not so okay. It's like, it's a weird thing that you see where it's either you get to a car accident, you look at it and you're like, wow, that person's got to be dead. And you look inside, they have no scratches on them. They're totally fine. They even pass spinal motion restriction criteria, right? And then there are other times where the car looks not that bad and you get there and the person is very close to death. So it's an interesting kind of toss up. Majority of car crashes, at least it's going to be like, oh, you know, I'm a little bit in pain. Oh, my knee kind of hurts. The little fender bender, my airbags went off a little bit, totally fine, or something really bad. It's this weird kind of toss up. Falls, we do see a lot, specifically in elderly populations, and that leads to our suspicion of high mechanism of injury that can lead to death. I was telling some people in lab, I have went to a call where the woman, probably in her 80s, did not survive from a fall sitting in her wheelchair straight forward. From her sitting position in her wheelchair, she fell, hit her head, and she died a couple hours later because she was on blood thinners. And when we got to the hospital and we did a CT scan, essentially half of her brain was just like compressed by blood. So just a small fall, never rule it out as a not major sign of potential injury. Motorcycle crashes, low speeds, these can lead to major injuries. There was one that I went to where a guy was probably going 25 miles per hour and a car turned and he just got clipped and went over. His leg was like twisted like a corkscrew. And when we got him to the hospital, he had a nick on his descending aorta that was slowly bleeding. In the back of the ambulance, he just said, "Oh, my stomach hurts." And we had no idea. We couldn't see anything. So we just got him there. And it turns out he was very close to death. We did not see signs and symptoms of decompensated shock because we got there within a certain amount of time. He was conscious. He had a really bad leg fracture, complaining of some abdominal pain. That just told us, oh boy, he's probably got something internal going on. Let's treat him for shock and go. Right? That's the best thing we can do. Hangings are a tough one. You're either going to find somebody who has airway issues, potentially some lack of breathing or like some hypoxia, to people who have been deceased for quite a bit. When we tend to see hangings, unfortunately, it's usually quite after the fact. People who are suicidal and choose to hang themselves usually choose to do it in a private place. So unfortunately, sometimes people just find them. When I was at St. Mike's, it happened. Somebody walked off into the woods like one night. The next morning, a jogger found them, a student who was a couple years older than me. And I know that something similar happened at UVM recently. So these do happen, but unfortunately for us, we can't usually help these people. If we do get there in time, we're likely going to be needing to take airway and C-spine precautions. They could have damaged airway. They could have damaged vessels. They could have not breathed for a little bit. Anything along those lines. I think this may have been diving accidents. I don't know why driving accidents is different than motor vehicle crashes. And then a recreational accident. So, you know, people playing games. Oftentimes injuries happen when you don't expect it. So I wanted to talk a bit about spinal motion restriction and just backboarding a little bit more. We did talk about it and we did some scenarios. I know that we didn't get to, not everyone got to do all of the scenarios on Saturday, but the one that I was doing was based around somebody who needed spinal motion restriction and some splinting, but was not meeting the criteria of a severe patient. So they were rollerblading, they got hit by a car, they were complaining of leg pain. And when you got to scene, they had some abrasions on their arms and legs, and they were also kind of just like holding their head. So again, with spinal motion restriction, the whole idea is that stabilization. If we're considering that there's a broken bone and we need to manually stabilize it so that it doesn't get worse, it's the same thing. We don't want their spine to get worse. We want to reduce the amount of movement they have in their cervical spine that could cause them to suddenly make an injury worse and sever it and essentially die. So that C-collar isn't a complete immobilization, right? They can still move a little bit and they could really force their way out of it. It's not completely immobilizing somebody like a backboard is. So if we see somebody who has any of these symptoms, this pretty much tells us they have a spinal injury, right? So what we are assessing for when we do that spinal motion restriction checklist is to rule out any of the major things that would tell us right off the bat, you have a spinal injury. So essentially, if they have any pain in their head, neck, or back, not just their neck or back, likely have a spine injury. We can't say for sure without an x-ray, you get a C-collar, right? But if they have tenderness, if there's a physical deformity, if they're reporting some tingling or numbness in their hands or their feet after an injury, if they have no sensation at all, or they can't move an injury, like an extremity, if they're incontinent, so like if they've defecated or if they've urinated unintentionally, or if you can see physical trauma to the head, right? All of these things tell us, wow, they likely have a spine injury. We should take precautions. So unlike backboarding, right, like this Barbie is down here, we don't really do this anymore. And me in the video here, I'm getting put into a device called a Kendrick extraction device. And this is in here just because it's funny, because my friend there tightens it too much over my face. So it just kind of looks scrunched. I was probably 18 in that video. There you go. So scrunched down looks all funny, but what he was securing me to is this. It's a seated backboard. And this used to be an NREMT skill sheet. Thankfully, it's not anymore. You would have had to learn this and backboarding, and this was going to be one of your random stations, but we don't do this anymore. So this was for somebody who was seated in a car who had head, neck, or back pain, and we didn't want to move them to get them onto a physical backboard. So we could slide this in, you put the things around, you buckle them all in, and then it acts as like a backboard for their seated position. Very rarely used. I never once took this out on a real call. I just got very stressed out about it for testing purposes. Never once got tested on it. However, we can still use this. I don't know of any direct service that still carries these, but they still can be used as pediatric backboards if you need to transport a kid quickly. So reminiscing, of course, anytime anybody had head, neck, or back pain or tingling in their fingers or anything that could lead to a spinal injury or suspicion of, they got fully immobilized on a backboard. So 10-minute station, right, we would do on these patients. I just remember thinking back to how stupid it was when we had to do a standing takedown on this nice man who had just the tiniest little pain in his neck. But because he said it to us, we had to do that whole takedown, transport him to the hospital completely immobilized. So again, through study and through just use of these things, we found that it wasn't good. Hard surfaces don't really inspire stability or comfort on curved spines, especially if they're broken. So we tended to make pain worse, if not make injuries worse, and just make these people really hate going to the hospital. So now we do spinal motion restriction, but we still use those backboards. And that's one of those things I wanted to talk about, because in that scenario that I did, there were quite a few people who wanted to fully secure them to a backboard, which isn't out of the realm of possibilities, right? We were talking about it. They had minor trauma, but they needed to be in a C-collar, and they also had another injury, right? So the mindset behind it is, let's put them in a C-collar. We can completely immobilize their back, and we don't have to do a specific splint on that one leg injury. So let's put them on a backboard. That way we do it. But that's not really how we use those anymore. So while that's a good idea, our main goal, if we're using a backboard, is to get them off as soon as possible. So really, if we're going to secure somebody on a backboard, they have so many injuries that there was no other way for us to transport them, right? Either it's super extensive, they have a life threat, we're worried about their ABCs, and we don't want to worry about their broken and flopping arms or legs. We just want them secure in a place where we can keep them. They're unresponsive most of the time, right? And it's less so about getting them secure and then moving them. It's more so about making sure that we are not hurting them any more than is just going to happen in general, right? So like if they need a backboard, we are going to be needing to extricate them for a while, right? It's not something simple as like, hey, let's just get you over to the stretcher, which we can wheel down the hall, go down the elevator, go right back out into the ambulance. This is somebody's ejected from their vehicle and down a hill in some off the side of the road, right? I'm not going to put somebody in a unsecure soft stretcher, like lifting them with the tarp up a hill in the rain, because they're just going to slide right out, right? It becomes a slip and slide. But fully immobilizing somebody with a bunch of broken injuries, spinal precautions to move them up a hill onto the stretcher, yeah, absolutely. So for the most part, we will try our darndest to never use a backboard again. Try your hardest to never let it happen. But if your patient needs it, you will know pretty immediately. And you will also be needing to like figure out the best form of transport or the best way to treat your patient with the other providers on scene. For the most part, majority of times you can get away with a C-collar and spinal motion restriction. That it is what it was made for. Okay. Any questions so far? I feel like I'm rambling.
This is helpful. Can you talk through like the sort of real world application of this flowchart a little bit?
Yeah, absolutely. So essentially, we're just trying to rule out the whole purpose. The way that I think about this is like, I don't want to say this. Just picture that you just made a nice meal and you got called for a fender bender. And in the dispatch, somebody says, patient complaining of pain, right? Okay, well, dinner is going to cool down in about half an hour. You know that it's going to take an hour and a half to transport this patient to the hospital. So in a very joking way, that's the way I'm phrasing this, because we're trying to get out of immobilizing their spine. We're trying to not have to do it by going down the line of everything that could be wrong that would require us to. So we're trying to get the big things out of the way first, and then we can kind of get a little bit more focused. So we're really just looking to see whether or not they need a C-collar. So you show up, it was a fender bender going about 25 miles per hour. It's a 30-year-old person, and you walk up and they say, oh yeah, my neck really hurts. That we stop right there. Spinal motion restriction assessment, they get a C-collar. Okay, because they have reported pain after trauma and they're over 18 years old. So essentially, if they're on, yep.
This says spinal pain. So if they like got a good whack on the noggin, but they're not complaining of spinal pain, they pass the rest of this.
So
Out of it.
mechanism of injury that could cause a spinal injury includes head injuries. So if they have pain in their head, neck, or their back, we have to consider.
So if the mechanism of injury could cause a spinal injury, they need a C-collar. We're done. I thought that was saying like then you go through the checklist.
Nope. So at the top, mechanism. So I'm saying if they had a mechanism of injury, but no neck or back pain, but they had head pain, like a whack to the head, means we have to assess their spine. And if they have pain in their head, their neck, or their back, they get a C-collar. So
Gotcha. I was just reading that third box up from the bottom, spinal tenderness on palpation.
yep. So that's when
But
we
it
get
doesn't.
there.
Yeah.
Yeah. So that like the beginning thing. So there was an accident. Okay, car accident. Yeah, that could cause spinal injuries. We need to do this assessment. Okay. Are you over 18? You are? Great. If they're not, C-collar. Have you had anything to drink? Are you super anxious, or are you a language barrier, right? If they can't speak English, we can't effectively communicate to them what's going to happen or why we need to. We can't understand what they're saying. So they get one, just precautionary. Are you drunk? Have you had any alcohol or drugs today recently? If any of these are yes, we say, okay, you don't have enough of a grasp on how you feel to be a reliable narrator. So you get a C-collar. If they have a distracting injury, so if there's an injury that is big enough or on them or somebody else to distract them from their head, neck, or back, they get a C-collar. So that includes their daughter in the back seat who has a broken arm, who's really upset and screaming, right? That's a distraction. They might not be a reliable narrator. So they get a C-collar. We're going to treat them. It also tells us that the accident was bad enough to harm somebody else in the car. So mechanism of injury transfers to them as well. Then after we've got kind of those general questions going, we really haven't done any physical assessment on them yet, right? We've just said, okay, there was an accident. They're not a kid. They speak English. They're not anxious. They don't have a distracting injury. They're not drunk. Okay, now we'll actually do some assessment on them. That's not just verbal. So we'll say, okay, do you feel any tingling in your hands or your feet? Can you move all your fingers and toes for me? Can I see you move them? If there is any tingling, if there's any pain, or if they can't move any of those extremities, C-collar, because that tells us neurological issue. Okay, so they don't have anything wrong. They can move all their fingers and toes, no tingling, no numbness. All right, that's pretty good. Broad neurological functions are intact. Now let's actually put our hands on you. Do you have any pain when I touch your head? When I go down your spine, do that finger assessment on the C-spine, check for step-offs, but also check the sides too. If there's any pain on those muscles, that includes spinal motion restriction. Go all the way down. If there's any pain on palpation, C-collar.
And that includes, in that earlier example, I think this is what I was not understanding. That includes any head pain.
Yeah. Because the head is so closely in line with that C-spine,
Sure.
we need to take that precaution.
I just was asking because it says spinal specifically, and I wasn't sure what to make of that.
Yep. Yeah. So really we are palpating the spine, but we do want to palpate the head as well. And then if they don't have any pain when we palpate, then we can start to say, all right, let's do something a little bit more dangerous here. Let's have you move your neck and see if there's any pain. So we're going to start with flexion and extension. So forward and back. because this is a little bit more safe for the spine if there is an injury than moving it to the side, right? So we start like this. If there's any pain here, C-collar. But if there isn't, then we can say, okay, last step, go to the sides. Are there any pain there? And if they say no, then we can say, awesome. So do you want to go to the hospital today? I do not think that you meet the criteria for a C-collar or spinal motion restriction. If you don't have any other reason why you want to be seen up at the hospital, we could probably go about talking about ways to cancel this, have you sign some paperwork, send you to your doctor later today or tomorrow, right? But if at any point they hit those things, that's when we need to treat them as if they have a spinal injury, as if their spine is broken. So they get the C-collar and they need to be laid completely flat on the stretcher in that supine position. And the hospital gets very upset when we bring in somebody who has a C-collar and is sitting up straight, because a lot of people don't like to lay down on the stretcher, especially if they don't think they need to be going to the hospital, but they meet criteria for spinal motion restriction. This happens quite a bit. They don't like to be laying down because it kind of amplifies that feeling of lack of control, right? You're moving, you'd actually be moving backwards if you're in the ambulance. It feels kind of weird. A lot of people don't like that. And they just want to be, they want to request to sit up or get a pillow. We have to be pretty strict on this. We need to keep them flat and protect their spine. That's a really big deal. So don't be afraid to be like, hey, I know it might not be comfortable. We got a 20-minute ambulance ride. And I just want to make sure that if you sat up, you know, your spine injury didn't get worse and lead to paralysis or something much worse, right? So if you could lay flat for 20 minutes, I promise, as soon as the doctors figure out what's going on, you'll know if you can sit up or not. We got to be honest. But again, we can never really force anybody to do anything, especially if they're conscious, alert, and oriented ×3. So if they're gonna sit up straight or fight you to do it, let them sit up straight and just document so hard how you told them not to do that and how you told them all the reasons why. Did that help with this? This is definitely a cumbersome protocol. So lucky for you guys, again, you're not going to get tested on this in an EMT. As long as for trauma, you actually stabilize the C-spine, right? Or you direct your partner to do that. And in medical, as long as you state that you are going to consider C-spine, then you're good. You won't have to go through this, but we will be likely needing you to utilize this in scenarios. It's just going to help you. Okay. So you don't have to get this perfect, right? This is going to come for when you practice in Vermont, but remember the purpose of it. The purpose is, I am worried that they are going to be paralyzed and dead. But maybe I can chip away at that a little bit by asking them some questions, seeing if there's anything that makes me suspicious of a spinal injury. So take good care for the head, that C-spine, and especially the lower spine into the back. So applying the C-collar, we did talk about this in lab. The sizing of it, they teach you to do that fingers, right? Put it up to the jaw, see which one lines up with the jaw. Then you take your hand and you put it on the C-collar and you see which finger lines up with which hole. Pretty subjective, right? Based on someone's hands. So again, I always say the best way to do it is to just place it under their chin, have it rest there and size it that way, right? You can see if it needs to be moved up or down by taking that front part and cupping it up to their chin. It's kind of interesting when we're applying it, the way that we should hold it is essentially like we have our hand around their throat, but we're going to be holding that piece of plastic, right? So we're not actually squeezing their throat, but we want to shape it to that part of their jaw. So you want to hold it like that against them and then wrap the side around and Velcro it pretty tight. Always be confirming with your patient that they feel okay, that they can breathe, that they can swallow, because as soon as it starts to be uncomfortable for them, they start to naturally kind of do this, and we don't want that to happen because that is just movement of the C-spine. So if we are going to backboard the patient, and I wanted to talk about this because I heard some people kind of mention it during lab, is that one of the scenarios they were doing a trauma assessment essentially, and they were told that when they apply a C-collar, they have to hold that person's head the entire time. That is not accurate if we are using spinal motion restriction. If we go through that assessment and we do determine that they need a C-collar, we can apply the C-collar, have them lay down flat, supine position, and you don't need somebody holding their head. However, if you are going to backboard somebody and go through that whole process of putting the head blocks on to move them, you do. So it's not about if you put a C-collar on, it's about if you are going to fully immobilize them in a backboard versus if you're going to use spinal motion restriction. Does that make sense? That's one of those weird Vermont to national kind of protocol deals. Also, go ahead.
So you're
Go ahead.
saying in a trauma situation, if you made the determination that you're not going to backboard the patient, you could stop manual stabilization?
Yeah, if they meet criteria for spinal motion restriction, yes, you don't need a person on the head if they're laying supine on a stretcher. If you are going to backboard somebody, you need somebody to be manually stabilizing them throughout the entire process. That's because if you're putting them fully on a backboard to immobilize them, there's going to be people moving around. There's going to be other things on scene. So we just want to make sure that that head stays stable until the head blocks are applied to completely protect it. But if they meet spinal motion restriction criteria and we've got them on our stretcher flat, they don't need it. So you're not going to really have a person who is unresponsive with just a C-collar on, right? We need to protect their C-spine. So if they're completely unresponsive after trauma, we should probably be putting them on a backboard due to their injuries. But if they're conscious, if they're alert, and we've met them for spinal motion restriction, right? We don't need to have somebody holding their head the entire time. The idea is that the patient will control their own spine based off of their pain. But if we're really concerned that they have a spinal injury, we should have somebody be holding their head.
And with the backboard, once you put the blocks in place, are you supposed to continue to hold the blocks to provide manual stabilization, or can you let go of the blocks?
So when the blocks are first applied and the head straps haven't been put on, someone needs to be holding the blocks. But as soon as those head straps are applied, then they can let go. Essentially the last step. So Jesse, C-collars do not have to be applied while somebody's laying down. That's just kind of the typical way that we'd find somebody if we're going to backboard them. And that's why we were using it that way. And if someone's unresponsive after trauma, you'll likely apply it to them while they're laying down. But there are plenty of times where we might apply it to somebody who's seated, typically in their car, right? If we get there and they've got neck pain and they're sitting in their car, we're not going to take them out, lay them down flat to apply a C-collar. We can just put it on while they're sitting in the car and they can get themselves out. And then Connor, you asked, why is the right nasal preferred for an NPA? And that's just because the people who manufacture the standard NPAs used a right nostril mold for it. So all of them are essentially molded to a right nostril. So it could have been either one. They just picked the right one to universally mold it to. So that's why. And it's because of the bevel. Right? Like if that needle point of the airway is against the wall of the throat, like if we put it on the outside, it could just get pushed against the wall. And if we try to push air in, it's going to get stuck. So that's why we always do bevel in, try on the right nostril first. And if you can't, then you go to the other side. And you just want to make sure that the bevel stays in towards the septum. No, so I'm saying if we are on scene with an unconscious patient and we are going to use a backboard them to get them to the stretcher, once we got them on the stretcher, we can take them off. But if we are going to go about the process of completely backboarding them, we need to do it correctly, which means we need to have somebody stay on head the entire time until the head blocks are applied. So we can apply the head blocks, pick them up, take whatever extrication path we need to get them onto the stretcher, and then we can take them off the backboard. But depending on their level of injuries, if they've got 2 broken arms, a broken leg, and a life threat, I'm just going to leave them on the backboard and get them to the hospital. But I put them on there for that splinting, so I don't have to worry about splinting their extremities. But say they're unconscious, they have a broken arm, and maybe they have a life threat. I'm not going to fully backboard them. I'm just going to put the C-collar on. I'm going to get them to my stretcher. I'll have someone splint that single extremity, and I'm going to worry about all the other stuff. But it's more so do you want to worry about 6 broken arms, or do you just want to go about backboarding? Because if you strap them onto a backboard with their arms and their legs in, you have successfully splinted all of those without having to go through and splint in like the 4 different extremities.
Is there an expectation that you would splint broken bones on the way to the hospital?
Yes.
Even if
If
it's
they
like
have-
a
if-
15-minute ride?
Yeah. If they have an injury, we need to make sure it doesn't get worse. So if they're sitting in the ambulance and they have a broken arm and they're not on a backboard, it's our duty to make sure it doesn't get worse. So we should splint it, which is why a backboard is a great tool in some senses, right? It's not good for maintaining spinal motion restriction. It's good for being a full body splint. So if they have a lot of secondary injuries, we don't want to worry about those. We can just backboard them, get them to the hospital. But if they just have a life threat, like if we need to bag them, or say they had a sucking chest wound and we're kind of working through that, but that's their main injury. Say they just got stabbed once, they have a hole in their chest. We're really just going to be occlusive dressing and helping them breathe. That's still a life threat. That's major, but they don't need to be completely backboarded. But say that guy got stabbed once, had his arm broken by a baseball bat, right? I'm going to splint that arm because it could get worse. It could lead to more things after I've occlusive dressing him and worried about oxygen and stuff like that. So we never want to focus on the splinting. We want to take care of those life threats first, but after we take care of that, yeah, we should do our best to make sure we treat all the injuries. And if you don't get the opportunity to, maybe your transport is too short. Like if you're working in Burlington, you're not going to get the opportunity to splint an injury. You're going to get in the ambulance, you're going to do some treatments, get there. As long as you've noted where they are and you can tell the hospital where those injuries are, that's the best thing.
But like
Oh,
getting
sorry, go on.
sample history would be a higher priority than splinting. If you couldn't do
Yeah.
both at once.
I feel like you should,
maybe you
I mean,
could. Okay.
if you, what is the standard practice for an assessment? Is it scene safety, BSI, ABCs, splint injuries? No, we always kind of put that sample in that medical history and the life threats and finding out about our patient first. If they're unresponsive, it's always just going to be ABCs, life threats, secondary injuries. But if they're conscious, yeah, we should try to be doing our best medical assessment. It's also not too far out of the realm of possibilities for you to do 2 things at once, which to be holding manual stabilization. Hey, has this happened to you before? Do you take any medications? You know, that kind of stuff. This is why this kind of topic, right, where there isn't a direct way for me to say every single patient with this, do this, every single patient with this, do this. That's why I tend to say that EMS, being an EMT, it's a function of being like practicing an art that is described as a science, that is based in science. So we have a general protocol book. We have an idea of what we can do. Mine's right here, right? It's outdated now. But if I was ever nervous or scared, I didn't know what to do, I could look right in here, and usually there's something that tells us what to do. But there's going to be something that you encounter, and there's going to be plenty of times where there's something out of the ordinary or something that doesn't line up with the protocol book. And you're going to have to be creative, and you're going to have to think on your feet and really use the resources of what's around you to get somebody out of the situation. You might do something that isn't technically in the protocol book, but it's not outside of your scope of practice. The thing that I think of the most is a very obese woman fell from a standing height. We didn't know this at the time, but broke her femur. We had to break a window to get in because we were outside for about an hour trying to find a lockbox, trying to get in touch with her landlord, trying to find a neighbor who had a key. Nobody. We could see her from outside. We couldn't communicate with her. She was just screaming. So we broke a window and we got in. And this woman was close to 600 pounds, probably a little bit heavier. So we tried to use our soft stretcher, and when me and some firefighters went to go pick her up, the handles broke off. We didn't have a thing, and we couldn't physically lift her high enough to get our stretcher underneath her while also stabilizing her leg and all of this kind of stuff. So we didn't know what to do. We were considering, like, do we call more firefighters? Do we wait for another service to get here and we try another soft stretcher, whatever it was? And I had one of the guys, we're out in Heinsberg. He pulls me aside and he's like, hey, I don't know if I should bring this up, but I just bought a new harness for hunting that is great for moving moose. And really the whole purpose is it's just so that you can get in with a bunch of people and lift it straight up so that you can back your truck right underneath it. And I was like, you have that with you right here. And he goes, yeah. I was like, go get it. So we got it. We rigged it up. You kind of step in. It was like a harness. You tie yourself in. And so that you can tie it. And when you squat, you get like lifting with your hips, but you also lift with your back. So me and the 5 firefighters, we just lifted her enough to get the stretcher underneath. And then we got out. We were on scene for like 2 hours trying to figure this out. We were getting really tired and we didn't know what to do. Right. So we just were like, what do we have with us that we could use? We would have had to think of something else. Right. So these are the times where you have a minimum, you have a baseline of what you need to do. And that is ABCs, being a good provider for your patient, letting them know that you're thinking of them and that you're there for them to help them. But then really what you have is a toolbox, which is your ambulance full of toys, which might help in this situation. And you, using your training and the experience that you're going to get, need to figure out which one is the best. And that's really going to be up to you. We have those baseline that we need to check off. Sure, C-collar, let's do some manual stabilization. But I think in this situation, a scoop stretcher might be best, right? We're going to have to think outside the box. So that's kind of where your brain comes into it. Okay, I'll give you guys a break. Let's come back at 7:15. See you in a little bit. It's got to show. Anytime I crack a can off camera, I like to show it just in case. All right, where was I going? Okay, share my screen. Okay. Another thing that I heard on Saturday from one of those scenarios, and just wanted to clarify something for you guys. So one of the lab instructors was saying that in trauma, that is a simple enough indication for us to check a finger stick, and we should be checking finger sticks on all trauma patients. That's not completely accurate for our purposes. That is more of the idea of paramedic level assessment and treatment. They can do something about it. For our purposes, and we talked about this a little bit with that group that I was talking to, we are only going to check a finger stick. It is only indicated for us if we can assess for altered mental status, or if we think that there's diabetes involved. So not every trauma patient is going to be altered. If they're unresponsive, which a lot of them can be, yeah, we're going to check a finger stick. But if they have a broken arm, or if they've got something along those lines, we're not really going to check a finger stick for a couple different reasons. One, if they're unresponsive after trauma, there's nothing that we can do as basic EMTs to correct that low blood sugar. We don't have any way to give them sugar if they're unresponsive. We can call ALS, absolutely. But that's, again, are we going to focus on treating their life threats, like if they've got an airway, breathing, or circulation issues, or correcting a blood sugar that's 55? Right. We're going to worry about their injuries, get them to the hospital where they can get an IV with some sugar. Again, for our purposes, check it if they're altered. Like if they're completely unresponsive, yeah, it's going to do some help, right? It'll tell us potentially, did they get in this accident or injury because they had low blood sugar? Yeah, potentially. But if they're unresponsive, we can't help besides pass that along to an ALS provider who potentially could. Just wanted to clear that up. That is definitely more along the lines of paramedic level thinking, because they're going to be able to do something with that. They're going to use that information to help them determine other metabolic things that might be going on with the patient. Again, our purpose is airway, breathing, circulation, focus, treat those life threats, get to the hospital as soon as you can, and do as many assessments as you can that you think will help that patient. So if they're altered, if they're unresponsive, yeah, get a blood sugar, but just know that it's really going to be more so about passing that information along than actually doing anything about it.
Hey, Kevin, quick question. Are we ever going to bag a conscious patient?
That's a tough question. There is a potential that you might need to. If they're conscious and they have an injury that requires us to bag them, like if they're conscious but they're still breathing super fast, which is probably going to be more, I don't want to say more like common in trauma, but if they have an injury like a sucking chest wound or a flail chest, likely you can see sometimes the respiratory rate increase with them still being conscious. But it's going to be tough. So when we do bag a conscious patient, it's going to be us trying to figure out kind of how to work with them and how to do it. We can use a bag to somebody who is having like hyperventilation syndrome, and we can try to help them kind of feel when they should be taking breaths. If they're conscious and they're like fighting it, we can try to bag with their breathing, but trying to slow it down. It's going to be a challenge, but yeah, you might have a time where you need to bag somebody who's conscious. It's pretty much going to be solely, if they're conscious, it's pretty much going to be that they're breathing too fast. If somebody's breathing too slow, they likely will not be conscious. Does that
Kevin,
help?
if I can add to that, Kevin, I've had
Sure.
patients who lived in the area who lived on ventilators for any number of reasons, and have something completely unrelated, like abnormal lab values. And so, yeah, as a basic crew, we had to take them off the ventilator and manually bag them for 10 minutes to the ED. Nothing's wrong with their mental status at all. They just can't breathe by themselves. So it definitely can happen. It's just rare, like Kevin said.
Right. I was thinking more like a stab victim, like you were referring to a stab victim. And so somebody who is unable to focus because they are either in pain or all over the place because they've been stabbed, but their respiratory rate isn't supporting their system. Is that a situation where we'll have to do it? And if so, is there a secret? I'm sure there's no secret, but is that a situation where you would get into, and what does that look like?
Yes, that's going to be tough, right? Like if they have a sucking chest wound and they definitely need to be bagged, like we can tell that they're going to stop breathing altogether soon, but they're still conscious and not really like willing to have us do it. If we have ALS there and it's a paramedic, they might consider chemically sedating that person, and then so we can bag them if they really need it as a life threat. Or if you don't have a paramedic there and it's just you, we're going to have to try to convince that person to calm down and let us bag them, or we're going to have to wait until they go unresponsive and start bagging them. It's tough. Like people, if you're anxious and you're having trouble breathing or you're breathing too slow and someone tries to bag you, it's like if you don't want that to happen, you're not going to let it happen. So we can do our best to like tell them that we need to and try to do it for them. But if they fight us and fight us and fight us, we might end up just needing to do blow by, or we're going to end up bagging them after they go unresponsive. It's a tough one. Yeah, bagging patients who are conscious is going to be a lot about you communicating to your patient and working with them on allowing it to happen. Otherwise, yeah, we're going to have to unfortunately wait. We're still going to do everything we can to get them oxygenated in between that, but yeah, there's not much we can do if they're fighting us on that. That would definitely be a chemical restraint type thing, because they're not alert enough to recognize that they need the bag to survive. They might not be alert enough to recognize they will die, right? So that would be paramedic level. Okay, well, we're going to sedate you then so that we can keep you alive. Oh, why did I skip this one? We didn't talk about it. So considerations for traumatic stuff with pediatrics. So kids who have been in trauma situations, these kids tend to compensate really well for a good amount of time and then essentially go right into irreversible shock. The trend for an adult would be like, okay, compensating, decompensating, irreversible. For kids, it's like compensate, and then they just drop right off. So if there's a kid who's doing pretty well after trauma, that's major, but they have some injuries, treat them with a high level of suspicion. They could decline really quickly. So don't allow their initial kind of how they present to convince you that they're fine. Do your assessment, but still really take care to assess, because they could decline really quickly. If possible, right, we kind of want to use their car seat. If they're still in a car seat and they're an infant small enough, these car seats are fantastic. Like if adults could have these, that would be the best possible thing. If we could move around in these all the time, they're fantastic when it comes to like protecting things from trauma and immobilizing things after trauma. So if a kid is still in one of these, transport them in this, pad the extra areas to make it a little bit more secure. But yeah, strap these right to your stretcher. If they don't have one of those, yeah, or it's a different situation, treat them like you would get them a C-collar pretty much immediately, and really do your best to keep everything all nice in line. They're definitely going to need extra padding because majority of our like backboards and stuff like that, our spinal motion restriction stuff is adult sized. Like unless you're carrying a specific child backboard, you're not going to have one. You see this kid is on an adult one. So you can see all the different blanket wraps and extra stuff they put in there to make him nice and secure. We do have devices for just standard transport of kids on the stretcher. So something like the PD mate, which is essentially just like a car seat that you can attach right to the stretcher. In a lot of ambulances on that spinny chief chair, there's an actual kid seat that you can pull out from it, which is kind of cool. So if you need to transport a kid that might not be that injured, excuse me, or if they're just going to be with their parent who's injured or something like that, you can use some of those. The main thing here, we are going to be doing essentially the same treatment for kids in trauma as we would with adults, but we just need to be a little bit more suspicious when it comes to kids. They can decline really fast. We also just need to recognize how this might affect ourselves. Treating kids is a lot more nerve-wracking to some people than it is adults. It can also just kind of elicit some different responses in our providers. So just keep that in mind. Kids are one of those things, especially when it comes to like severe incidents that really affect the crew, but also really affect the mood of the scene and the bystanders. Specifically when it comes to like cancellation, like tour and stuff. If we know that a child is deceased, like what are we going to do? For the most part, we're not going to cancel on scene for kids. We're going to transport and move. But a lot of the times that we end up doing that, we see it's because of the environment rather than exactly what's happening with the kid. The calls with kids are definitely the toughest they were for me at least. So with these pediatric considerations, like the reasons trauma really affects them so much is just they have a less surface area of their body, right? So like the percentage of potential life-threatening injuries kind of just increases because there's more of a chance of a larger part of their body being hurt. They have less blood, they have less fluid in general than us, so they can really get dehydrated or hypovolemic really quickly. And their airways are much smaller and harder to manage. One thing about infants and kids is that when we're talking about opening their airway, we're not going to use the standard head tilt chin lift. We're going to do something called the sniffing position. So if you've got an infant, we're not going to take their head and their chin and we're not going to tilt it, because in an infant, that motion can actually close off the airway because it's so small. So what we actually do is we're going to fold a towel once in half. We're going to place it underneath their shoulders so that their head kind of just leans back a little bit. We push their chest up a little bit and their head kind of falls back just a tad. That's called sniffing position. That is only for non-trauma situations. In trauma, we're still going to do that jaw thrust underneath their jaw, lifting it up off the back of their airway. But in things like cardiac arrest or other situations, if they're having trouble breathing, we're going to use that sniffing position. So their nose just a little bit in the air due to the towel underneath their shoulders. Okay, that's what I had for the review of trauma. And then I was going to get through just review of pharmacology, maybe a little bit on CPR, and we'll see where we're at from there. Is there anything about trauma you guys want to review before I move on?
I do have one question that I know came up, but I never heard the final answer on, which was the auscultating lung sounds and what we were and weren't allowed to describe.
As far as the NREMT goes, you are allowed to listen for presence and equality of lung sounds. You are not allowed to report on findings of bronchi, rales, wheezes through a stethoscope. If you even look at the NREMT basic teaching standards, it doesn't even include auscultation as a skill that we're supposed to teach, but it's included on the skill sheets. So we do stick to that. That's what Chris and I were taught. That's what pretty much every instructor is told. As a basic EMT, you are not allowed to make the determination between the different sounds through a stethoscope. Do I think you absolutely could? For sure. But it's not within your scope of practice.
I
Thanks.
have kind of a broad question about trauma. I know that you said like we'll always transport, or most of the time transport pediatric traumas, even if they're deceased on arrival.
Mhm.
Like, what is the difference for like elderly patients that are having like a heart attack as far as like getting them on the stretch, like loading and go versus like staying and trying to like treat them?
Yeah, so loading and going is when we're like, they're gonna die in the next hour. We want to get them to the hospital without dilly-dallying, versus somebody who has a condition or an acute thing that we could probably help out a little bit with, right? And we're not worried that they're gonna go into a cardiac arrest when we're with them. Somebody has an isolated bone fracture, like an arm fracture. We can absolutely stay on the scene, do a good assessment, make sure that we have the best splinting possible, take vital signs, communicate with the family, work out a determination of if we're going to take the patient in the ambulance, if they're going to go with the family, versus we get there, somebody's having crushing 10 out of 10 chest pain with difficulty breathing and an EKG that says STEMI. I'm just going to say, great, I'm going to finish my assessment in the ambulance as we get you to the hospital, that because you will die in the next 10 minutes. So that's the determination. And we kind of break it down to sick versus not sick. Will they die in the next hour to 2 hours, or could we hang around? And is there something that we can do to help them? Right. So for me, the ones that I rapidly transport on and I don't hang around on scene are the really bad ones, and the ones that are pretty stupid. So toe pain, I'm going to say, oh yeah, your toe hurts. You want to go to the hospital? Great. Hop in, walk yourself in. I'll do an assessment in the ambulance. Versus you have crushing chest pain. Okay, you're going to sit down. I'm going to do everything to make sure that you don't walk. I'm going to do everything to take you to the ambulance, but we're going to do it fast, because if you're having a heart attack, you could die at any second, essentially. And I don't want that to happen to me. I want you to die at the hospital. Did that help?
Yes, and like to further that question, like if somebody does, so like say somebody does code and like they're going into cardiac arrest and you're having to do CPR, like do most people load and go like in that sense?
No.
Or like do you, so like
that's a difference, because we
right.
can't do good CPR in a moving ambulance. It is so hard to do good CPR in a moving ambulance. We can't analyze their heart rhythm while in the moving ambulance. We can't shock them while in a moving ambulance. So it makes more sense for us to have a good home base and a place to work a cardiac arrest, because that's one of the only times that they can get similar care outside of the hospital than in. Right? If we're doing a good cardiac arrest, if we're going by our protocol, that's what the doctors would be doing too. Like the only difference is, do they have a paramedic? Do they have an IV or something like that in place? But even with an IV or an IO, there's no evidence to show that epi actually works, or that the fluid resuscitation actually works all that well. So we're doing everything they would do in the hospital, and it makes more sense for us to focus on doing the cardiac arrest, getting them back, and then transporting them to the hospital, versus doing poor CPR to get them to the hospital faster. Like at that point, they're already dead. We have failed. Essentially, if they went into, like, we didn't get them to the hospital fast enough for the doctors to do CPR, but we can do it pretty well. We're going to treat them as best we can. And if we get a heart rate back, or we shock them and there's a chance they could get it back, that's when we're going to transport. There are plenty of times that we do CPR in the ambulance, but it's after 20 minutes of work on scene. That's part of our protocol. As soon as someone goes into cardiac arrest, if we're on scene, we work for 20 minutes, and then we determine if we're going to cancel, leave them on scene and call them the police and the medical examiner, or if we're going to continue all the way up to the hospital. But if they're still alive, we want to do everything we can to get them to the hospital while they're still alive. If they code in the back of the ambulance, start working them right there. Don't tell your driver to wait. Tell your driver to pull over when you're going to analyze their heart rhythm and administer a shock, but get them going if they're in the back of the ambulance. Continue what you're doing. Don't just stop on the road. But yeah, you still need to do that CPR protocol.
I know that we're like technically not allowed to read an EKG as well, right?
Yeah, you can't. So you can't look at the line segments or the electrical nodes and determine what those say. And you have to say that this is what the monitor says when the printout happens. You can't, and that's really just a technicality. If you take off what the monitor says, you show it to the hospital, this is what the monitor says, they will likely take it and say, great, that's what the EKG is. But we just want to stay away from saying anything out of our scope of practice. And if we say they had a, like if I determined that this is what their EKG was, we'd be stepping out of our scope of practice. We just have to say the monitor reported their EKG as this, because the machine can
Okay,
mess up.
cool.
The machine
Kevin,
can,
if you
Right,
have
that
a-
was my question.
If you have a Lucas,
Um,
oh, sorry. Go on, Samantha.
Oh, no, you're fine. I was just gonna say, we had a patient, that had, we did a 12 lead on her, and the 12 lead had some findings, but, so when I called to, do the radio report, the hospital asked, what the EKG was.
so you can say this is what the monitor said. Like,
Yeah.
they're not going to get you in trouble if they say, what is the EKG, and you say whatever the monitor says. Like, that's not stepping out of your scope of practice. But if they're like, oh, the monitor's messed up, this isn't the right thing, what's the EKG, and you said something that's different than the monitor, you'd just be making something up and not reporting. So that's just one of those things I like to say is the monitor says that this is their EKG, because I don't trust it as much as I should. It's just like, yeah, that's what it says, the lines look good, but I have no idea, so I can't confirm this is what it said. That's more of a CYA kind of thing. Cover
Kevin, I
your
was
butt.
just going to ask, if you have a Lucas, do you then change your protocol in terms of CPR and get in the ambulance and go, or does that not change the protocol?
No, so we still, if we're on scene, we're still going to do our 20 minutes. And then if we're going to transport, then we could use a Lucas device on scene, but we still do 20 minutes. Then we decide if we transport or cancel. We can transport CPR a little bit easier with like a Lucas or an auto pulse, because you can free up your hands from doing compressions, but it's not going to make us leave scene earlier if we have one.
Okay, thanks.
Yep. Great questions, guys. Cool. So, pharmacology, the 5 rights, of course. We do have a question, Leaf. Hold on. So after 20 minutes, I would transport if I had a shock at any point in my, actually, hold on. Let me get there. I have this in the presentation. Okay. Where maybe I didn't bring in the protocol piece. Here we go. So when we're doing CPR, we've got the AED applied, right? So we're going to stay on scene until we've delivered 3 total shocks. And if we get 1 shock at all, that tells us we're going to transport, but we still finish our protocol. So we stay until one of these things happens. We get 3 total shocks or 3 consecutive no shocks. So that's when we would stop doing our protocol. But determining on which one of those we had would determine on what we did. So if we had no shocks whatsoever, and we got 3 consecutive no shocks, that's when we could say, okay, I'm going to call the hospital. We're going to talk about canceling this person, terminating resuscitation, because I have not gotten a shock. We've worked 20 minutes and I've gotten 3 consecutive no shock advised, pretty much telling us there's no electrical activity in the heart. All the work that we've done isn't working. They're going to die, or they are dead. So hospital will likely confirm, yeah, sure, you can cancel. But if we get 1 shock and then 2 no shocks, and then 1 shock, and then 2 no shocks, and then 1 shock, that's when we're going to go, because we've hit 3 total shocks. Okay. So we could get 1 shock and then 3 consecutive no shocks. So we're still going to transport because we got 1 shock, but our protocol has ended because we got 3 no shocks. So it's kind of confusing, but in general, 1 shock, transport, but we're going to go until these 3 things, or one of these 3 things happens essentially. Okay, so back to up here. Good. So before we give any medication to our patient, we need to have the 5 rights. So is it the right patient? Is it their medication? Right? Is it the right medication for their signs and symptoms for my protocol? Am I giving it in the correct route? So I'm not going to crush up some nitro pills, put it in a spoon, heat it up a little bit with a little filter and inject it into somebody, right? No, I'm going to give them tablets underneath the tongue. The right dose, so I know how much of the medication I'm supposed to give. Luckily for our purposes as EMTs, a lot of those dosages are just pre-set out into pills. We're counting the number of pills. We don't have to do like per kilogram or that kind of stuff. And the right time. So is it within my protocol to give another dose, or is that medication expired? All that kind of stuff. So this is what we need to know. So right, the reasons to give the medication, because we think that they need it. Our contraindications are we think they need this medication, but we can't give it. The dose is just how much we give, how it gets in there, and what it does based off of those actions and those side effects. So again, these are the medications that you're expected to know about. The ones that we are going to focus on are oxygen, oral glucose, aspirin, Narcan, epinephrine, albuterol, and nitro. Again, you do have the opportunity to use Tylenol in Vermont. Activated charcoal is still technically in our national registry, but we are not really going to use it. And epinephrine, the only difference is Vermont gives you the ability to draw it up and inject it without using an EpiPen. So nitro, reasons we give it. We talked about this a little bit at the beginning of class. We're giving it simply for cardiac chest pain. Somebody is having a reduction of oxygen to their heart, probably if they're prescribed nitro due to atherosclerosis or a high cholesterol or a reason within their heart that would need the vessels to be opened. So because we can only give this to somebody who is prescribed it, that's a good sign that if they're having this chest pain, it's likely going to be cardiac. We can ask them, hey, does this feel like your other cardiac instances? Does this feel like like it did when you're having a heart attack? Yes, great, likely cardiac. But this one does have quite a few contraindications, definitely has some of the more complex ones. So systolic blood pressure needs to be above 100 in order to give it. If it is below 100, we cannot give it. You would be putting your patient in danger. If they've had more than 3 tablets already that day, they cannot have more. If they have an allergy to it, they should not be prescribed it if they have an allergy to it, but we should still ask. And then have they taken sexually enhancing drugs within the 48 hours? So this is any patient you're going to give it to. I don't care if it is 18-year-old Jimmy or 99-year-old granny, like ask them this question. If you don't, that's bad. If you don't ask the patient in your medical exam, have you taken any sexually enhancing drugs today before I assist you with your nitro, you will fail. Okay. Dose 0.4 milligrams per tablet. If you are using the spritzer, 1 squirt equals 1 tablet, so 0.4. And we want to assess their blood pressure in between our doses. We can give up to 3. And we can do that 3 to 5 minutes apart, depending on their blood pressure and depending on their signs and symptoms. So remember, because we give this for cardiac pain, if we give them 1 tablet and then in 3 to 5 minutes later, we assess them and we say, hey, how's your pain doing? And they say, you know what? It's much better. Great. You don't need more nitro. Excellent. We stop right there. But if they say, it's still really, it's working, it's hurting, right? Then we could consider giving another one. Yeah, Kathy, it does list head injury as a contraindication. Trauma is a big contraindication. Anytime somebody has a head injury and they're complaining of chest pain, I'm going to really think that it is, or I'm probably going to assume that it is trauma related. So I will do that assessment to make sure it's not trauma. So yeah, we do want to go through and mark these things off. If somebody only has chest pain and you think it's cardiac, we're going to go by these. If they have chest pain, you think it's cardiac, but they also have a traumatic brain injury, something else is going on. This one goes under the tongue. We don't have them put it under the tongue and then swallow. We just have it dissolve. And it's a vasodilator, so it really opens up those vessels. Or if you're an original Star Trek fan, those vessels. Okay, side effects here. So just actions can lead to severe hypotension. If we give it to them, they have another drug on board, like more nitro or a sexually enhancing drug. Or if they've never had it before, which they shouldn't because they're going to be prescribed if you're giving it to them, they could have severe hypotension where their vessels just open and they essentially have psychogenic, or not psychogenic shock, but something similar. Like they'd have a syncopal episode, but it could also lead to really bad shock. The other ones are kind of like iffy. It's just more so along those lines of I'm giving it to somebody, they might report that they're feeling kind of a headache. Pretty normal because we're just opening up all those blood vessels. And then also they could have some tingling from the drug actually perfusing through their mucous membranes. So again, we're only giving this for cardiac pain. So we can palpate. If they have no pain on palpation of the over the area, could be potentially cardiac, because if it's not stimulating that muscle, right, we can't palpate the heart. We'd be putting our fingers through their rib cage and muscle. So if it doesn't hurt on top, potentially cardiac. But if it does, likely not, because then you're probably just seeing a musculoskeletal, maybe even like somebody has bronchitis. If they're coughing a lot, they could have some like tenderness, kind of like right here, right? And it would exert pain on palpation. If they have normal or wet lung sounds, so you can distinguish this through listening with your ears and listening with a stethoscope. You can say, wow, those lung sounds sound wet. You just can't say, wow, I hear rhonchi and rails or crackles. So if it's normal or they have some sounds in there, could be potentially cardiac, might not necessarily mean it's a heart attack. It could be CHF, but those oftentimes go together. And if they have diminished lung sounds, it's likely not cardiac, especially if you don't hear any liquid sounding stuff. It could be like a pneumothorax or something along those lines. Now, when we do our thorough assessment, right, if it's crushing or tight, or it feels really heavy or a weight, that's pretty standard cardiac reported pain. If they have a history of a heart attack or angina, right, and they're prescribed nitro, likely cardiac. And if they have an EKG that says STEMI or MI, definitely cardiac, because if that EKG is telling you they have a heart attack. It's totally possible that it's wrong, but we can't determine that, so we treat them for a heart attack. So again, the action of vasodilation, we've got our vein or our artery, and it's blocked by a clot, reducing the amount of blood flow going by. So without it, it's hard to breathe. The heart is actually suffocating. That's why we get that pain. We put nitro in there, and we see that our artery will open up around that clot. The clot doesn't go anywhere, but more blood is able to get through it, and therefore making our heart, a little bit happier. So that's why we're giving it. We're trying to open up those vessels, get more blood-filled oxygen through past that clot. In combination with oxygen, this works really well. In general, that's what we give oxygen for, is to get that really necessary molecule out throughout our body. So we're giving it for SpO2s lower than 94. We're going to give it for people who are having difficulty breathing. We're going to give it for shock. We are going to give it for cardiac chest pain, specifically if we're considering that they have cardiac compromise. We don't want to overdo it. We don't want to blast them with it. But again, high flow oxygen for an ambulance ride, it's not going to change their outcome that heavily. And with the new protocols in that COPD protocol, at least the medical directors want us to focus on providing enough oxygen rather than worrying about that little less of an SpO2 reading. Contraindications for this is if they don't need it. There's not really any reason that if we gave somebody oxygen, it's going to make their outcome worse. We just don't want to give it to people who don't need it. So if they're not having difficulty breathing, if their SpO2 is not low, if they're not in any of those other situations, probably okay without it. Dose is kind of per person. High flow, that's pretty much what we focus on. So high flow oxygen, 10 to 15 liters through an NRB or a BVM. But depending on the regulator, can go from like less than 1 liter per minute to 25 liters per minute. A D tank, or like a dinky tank, like we pretty much have in labs in the bags, those could probably last, I want to say, like upwards of 45 minutes at full blast. Like if you turn it to 25 or like 15, 45 minutes to an hour, maybe, if you're lucky. So just keep that in mind. If you have a D tank and you got a long transport, or you need to be on scene for a bit with somebody with high flow oxygen, just get ready to know that you might need to switch tanks or hurry up and get to the ambulance to switch over to the rig oxygen. Route is inhalation or us forcing it down there into their lungs. So positive pressure ventilation with a BVM. Action, it increases blood oxygen levels. That's great. Just definitely a benefit. And side effects, it reduces strain on respiratory and circulatory systems because it doesn't have to work so hard to circulate that oxygen if there's a surplus. So again, very dangerous to handle. I won't show you those Mythbusters videos again, but it can turn into a rocket if it's sheared at the top, which went through that concrete wall like we saw in that video. It also amplifies fire, really feeds the flames, literally. So, oral glucose, and the guy driving by my house really loudly. So indications, low blood sugar. Not less than 80 blood sugar, but specifically less than 60. So less than 80 means that they're hypoglycemic, but less than 60 means that they should be corrected with something stronger than just food, right? Our only contraindication here is if they can't swallow, right? Like I added hyperglycemia on there just because, I mean, I hope you wouldn't give oral glucose to somebody whose sugar is too high. But the main thing is if they can't swallow, we can't give it to them. There are some, and I have heard this, some people and providers who say that if you rub, like you get some oral glucose on your finger and you put it on their gums and like in their mouth and stuff, it's enough to wake them up sometimes. Don't do that. Don't. You're just increasing the chance of them aspirating or vomiting, and we just don't want to put our fingers into people's mouths all that time. So if they're unresponsive, call for ALS. If ALS isn't around, manage their airway, bring them to the hospital. The dose, 15 grams, it's pretty standard, and wait 15 minutes to reassess. Even without like our oral glucose and stuff, diabetics in general are kind of told if your sugar's low, start with 15 grams, wait 15 minutes to reassess to see what else you got to do. So even if we show up and somebody who is a diabetic has a sugar that's like below 60, or not below, above 60, but below 80, that's one of those times where you could be like, hey, let's make you a sandwich, like have a glass of orange juice. Let's hang out for a little bit. We'll reassess in 15 minutes. If you're back to normal, great. We'll have you sign the paper and be on our way. We could even do that if they are below 60, just to a limit, right? Like if they're super altered or all that kind of stuff, we don't really want to sit around and wait. We just want to give them the meds and get going just in case something else happens. But we still want to wait that 15 minutes to reassess. If we wait like 5-10 minutes, we likely won't see any change in their blood sugar. So wait that 15 minutes to see if it actually comes up or not. Route, oral, it's in the name, have them swallow it. Increases blood sugar and side effects. If you're using the glucose or glucose like tubes, they taste pretty bad. So that's why we've got our maple syrup. Vermont Pure, not anything else, Vermont Pure. All right. That's what it says in the protocol. It's not just maple syrup, it's Vermont Pure maple syrup.
So if we give them the 15 grams, let's say we show up and they're extremely altered, we give them the 15 grams, we still wait 15 minutes before we transport them? Or do
so that's before reassessing the finger stick. You could absolutely transport them before that, but
Okay.
You're not going to get a reliable next finger stick if you take it before 15 minutes. So transport them. If you end up taking another finger stick in the ambulance, or if your transport is less than 15 minutes, that's totally fine. They'll check another one at the hospital. For the most part, people with diabetes, if they have a hypoglycemic event and they're conscious enough to get oral glucose, that's usually as far as it goes. Diabetes is pretty simply treated by us in emergency settings with, like hypoglycemia is, with oral glucose or with food or something along those lines. But they can start off pretty altered. Be just conscious enough or alert enough to swallow and follow commands to take the sugar, but it might not make an effect in a timely enough period where you'd say, okay, I feel comfortable about reassessing here. Might be like, let's get them that sugar so that they only get better on the way to the hospital. We don't know if it's going to completely fix it. So again, similar to how it's like call for extra help and then cancel if you don't need them. It's always better if somebody's altered to start going, bring them to the hospital. If they're doing better by the time they get there, they'll be released pretty soon. It's not that big of a deal. But we definitely want to treat low blood sugar. Activated charcoal, gross. So indications, poisoning by ingestion, pretty much revolving around pills. It's mainly for that kind of stuff. It's not really going to help if there's like bleach or things like that ingested. It's more so for that chalky kind of pill ingestion. Contraindications is similar to oral glucose. They don't have a patent airway. They can't manage their airway on their own. They can't, drink anything. They need to drink the entire bottle, which is the dose. The root, oral, they got to drink it. Actions, it adsorbs some toxins. I got corrected in my lecture one time because I had absorbs. It's actually adsorbs, guys. Keep that in mind. And side effects, bad taste. People usually vomit and their vomit becomes black. Gross. No longer in our standing protocols, so you're not going to get tested on this for an EMT, and you're not going to need to use it in the field here. Aspirin, cardiac chest pain, similar to nitro, but we are giving this for a completely different reason. And this one out of the two is the one that actually has a positive effect on people's outcomes from cardiac events. Nitro doesn't have any positive outcome, just has reduction of pain. Aspirin has positive outcomes. So this one we give first. Contraindications of this one, if they have a bleeding disorder, it could heighten that. It's also pretty harsh on the liver. So if they have known liver disease or disorder, or they're like a long-term alcoholic, we probably don't want to give this to them. Or if they've already had a standard full dose for an adult, which is 325 milligrams, but we give up to 324 because the pills, 81 milligram tablets, don't actually all the way equal up to 325. Whatever, it's 1 milligram works just as well. So we can give up to 4 tablets. We do have to do some math if they've already had some, right? So like if they're like, I've had two aspirin, we can only give 2 more. We just want to complete the dose. So with this one, we don't want to like give them a pill and wait a couple minutes. We want to give them 4 to start. We want to get them to that total dose as fast as we can, essentially. So if they've had 1, just give them 3. If they've had 3, just give them 1. Don't do like the nitro thing, which is like 1 pill every 3 to 5 minutes. Just give them 4 pills, get them to that full dose. That's the therapeutic dose.
What if the patient say took aspirin, or didn't take aspirin, but like took Tylenol because they thought it would help?
So we'd still give them aspirin because they're different drugs. It would still do the effect that we want. What we would want to inquire about is if they didn't know what kind of drug they took, we'd want to see what it is, because there are some drugs that you can get that have acetaminophen and aspirin in them and like that kind of stuff. So we just want to make sure that they didn't take anything that would mess with this.
All right.
Hey, Kevin.
Yeah.
I just looked at the updated protocols because I thought I remembered one of our instructors saying something about it. And the protocol now is if they've taken any in the last hour, then you complete the dose. If it's been more than an hour, you just give them the full dose.
Cool. That makes it a whole lot easier.
I think people should double check me on that, but that's how the protocol read to me.
Okay, cool. I'll take a look at that after this and make sure that it's all set. Again, those protocols have been released, but they are not in practice yet. I think they start either the 1st of January or December. So we were just talking about them. Again, it's not going to make a big difference for you guys in class. Actions, this is that one with that long term, that platelet aggregation inhibitor. Stops platelets from sticking together, just spawns them to kind of slip by each other. Platelet aggregator inhibitor. That is the term that you need to know to describe the actions of aspirin. Side effects, these are the most common that we'll encounter, which is a bit of nausea. They might actually have some vomiting, and then heartburn and cramps along with GI upset. Those are some big ones. A lot of people will also say I'm allergic to aspirin because they get some acid reflux or a little bit of like cramping afterwards. That's not them being allergic. That is just side effects. They would be allergic if they had hives, swelling, difficulty breathing, wheezing, that kind of stuff. So again, our purpose with this is dropping things in my room and scaring the crap out of me. Purpose is platelets are getting stuck on that clot building up. So we just want to give them the med to stop that from happening. If we give them the aspirin, those platelets aren't going to stick together and that clot is not going to get any bigger. So I took out my see the minnow fin joke for today, but still there in your hearts if you think hard enough. I also said famously, I don't know if it's famously, I just remembered saying this because I feel pretty strongly about it. I think giving us the option of giving PO Tylenol was a kind of stupid move. If someone really needs pain control, Tylenol is not going to do it. It takes a long time to kick in. And sometimes if they've had it, when they get to the hospital, they can't get anything else. So it's really dependent on you. It's going to be dependent on situations. Like if you're going to be out in the wilderness hiking to bring people a long ways down the mountain into the ambulance to then another 45 minutes to the ambulance, and they've got broken ankles or legs or something like that. Yeah, sure. Tylenol could probably help. But for the most part, if you're in a pretty like within a half an hour distance to the hospital and your transport times are within a half an hour, this medicine isn't going to help them at any point while you're in the ambulance. That's just kind of my thoughts on it. However, in the new protocols, I got excited to see that advanced EMTs, we can give IV acetaminophen, and there's a protocol in there for febrile seizures. So if a kid is having seizures due to temperature, like a high fever, because Tylenol can help with fevers, we can do a dose of IV Tylenol to help reduce that fever. That's a great use of it. But I just feel like the use case for like PO acetaminophen for like minor pain control, pretty rare. So the contraindications here, if they're allergic to it or if they have a hypersensitivity, similar to aspirin, if they have a known history of like liver disease or alcohol abuse, if they've had any other acetaminophen in 4 hours, we don't want to give it to them. This is another one of those tricky kind of things because the dose is up to 1,000, but we still can't give them any more if they've had some within 4 hours. So say they took 500 milligrams. If they took that within 2 hours, we shouldn't complete up to 1,000 because they've had it already. They've had a dose. That up to 1,000 is just that kind of baseline. And that's even lower than like the standard that an adult could take in a day. So it's really, have you had any acetaminophen within 4 hours? No? Great. I can give you up to 1,000. I'll probably give you one 500 milligram tablet. Or if you have, great. I'm not going to give you anything. We'll wait for the hospital. Root is oral. They have to swallow it. Yeah, the actions, you can look this up. It's kind of frustrating sometimes when they're like, yeah, we don't know. It's like a opiate, but non, and it's like an NSAID, but also not. I don't know. It does stuff. That's pretty much what they say. And then side effects similar to aspirin. It's hard on the stomach. It's hard to break down. So we got that nausea, those GI cramps, and maybe a little headache. Epinephrine, 1 to 1,000. This is for anaphylaxis. So poofy face after exposure to allergens, difficulty breathing, tingling or swelling in the throat, the tongue, hives, all the bad stuff. Contraindications is if the medication is expired, essentially. if the medication looks discolored or gross, and if they're not having anaphylaxis. I should also add here, for national registry standards, it's a contraindication if they're not prescribed the EpiPen. We can't give somebody else's EpiPen to them. This dose is the first one that we see that has a kid and an adult dose. So 0.3 for adults and 0.15 for kids. We give this as a shot, as an injection into a muscle. So if we're using the auto injector, it does it all for us. But if we're using Ready, Check, Inject, we will learn how to find the deltoid and administer in there. This one has two major actions. The one that we are most concerned with is that vasoconstrictor, and bronchodilator definitely helps. But remember, if somebody's having that anaphylactic reaction to the point where their airway is swelling, the reaction that we want, or the action we want from the med, is to reduce that swelling by clamping down the vessels, opening up the airway, and then that bronchodilation will help with the opening up of the lungs. But the main thing is we want to clear that upper airway. Side effects, the side effects that you would get after an adrenaline rush. So if it's really strong, they're going to have some tachycardia, some anxiety, and they could be shaky or tremory. Narcan, one of my favorites. Opiate overdose, that is the indication. So again, remember, we're not giving it to somebody because they report they've done heroin, they've taken their meds today that are opiates. We're not giving it because they're on opiates. We're giving it because their respiratory drive is shutting down to the point where they will die due to opiates. Contraindications is no opiates and they're adequately breathing, right? If somebody is high on opiates, but they're breathing okay, they don't need Narcan. Or if we can manage their airway and keep their SpO2 above 94 without giving Narcan, great, let's do that as well. This is where, with the dose, it gets a little bit iffy. So we've got our 4 milligram Narcan, and we've got our 2 milligram Narcan. That's backwards. So minimum dose that you can give at one time is 2. So you would have to at least give this, but you could also give this if this is what you carry. Minimum to start is 2. Again, the reason why we differentiate between these two is this is only intranasal, but this is intranasal, IM, sub-Q, IV, IO, all the other different forms. And so if you're working on an ambulance, more likely going to be working on an ambulance that caters to ALS providers as well. So you'll likely have this. However, there are plenty of services that carry both, especially if you are like a first response unit or something like that. A lot of times these are like the Narcan leave behind kits. This is the lay person's type because it's super easy to use and to give, and it packs quite a punch. So that's likely what you do. If it's up to me, I'd say use this. Less is more a lot of the time, especially because these have been quite misused by some untrained people. And remember, it's not, you don't need Narcan to save someone's life. If you've got a BVM and and you can manage their airway, that's the minimum thing you need to do. You don't need to like drop everything, forget to bag just to set up your Narcan to give it an IM or IN, right? Manage the airway, set it up, give them 2 milligrams, keep bagging them, see how that goes. If you have this, great, use it. Intranasal. Up the nose for you guys. It is an opiate antagonist, but again, that little asterisk there kind of disagreed upon in science because it does meet criteria for something called a reverse agonist. All kind of sciencey. For our purposes, opiate antagonist will work just fine. Side effects can be vomiting. And again, Narcan does not make people aggressive. People who have rapidly changing mental statuses, going from feeling really good to feeling really, really crappy, are aggressive. If Narcan's side effect was aggression, if I took this Narcan right here, there's a potential that I could get aggressive. I would just have a wet nose. Okay, it is not a side effect that it makes people aggressive. but it can lead to aggressive people rapidly changing mental statuses. And if they get too much too fast, like that one time that cop gave 20 milligrams in 30 seconds, they can have flash pulmonary edema and end up in the ICU for a long time and be the most annoying patient I've ever had. So again, my favorite little picture here, Narcan seats itself in the opioid receptors in the brain, even knocking out already bound opiate receptors. And then it sits nice and tight in there and blocks all the other opiates from getting to those receptors. So it essentially makes the opiates in the blood null for about 15 minutes, and then it can wear off again. Albuterol. This is that breathy one that's not oxygen, if you guys know what I mean. So difficulty breathing with suspicion of bronchospasm or bronchoconstriction. So for your purposes, if you can hear somebody through their mouth with your ears without a stethoscope in it, making wheezing sounds, give them albuterol. They are indicated. If somebody's having difficulty breathing without wheezing, albuterol is not going to help. Okay. The whole purpose behind that is because it is a bronchodilator. So if their difficulty breathing has nothing to do with the constriction of their bronchioles, this drug's not really going to do anything except amp up their heart rate already, which could make their feelings a lot worse. So contraindications are that they're not having wheezing, right? It's not going to help in that situation. And for our purposes with National Registry, we can only assist 3 puffs with a spacer up to 4 times, total of 12 puffs. But the great state of Vermont has a little bit of sense and allows us to use a nebulizer or a duo neb. So we can do that as well. If we are just giving albuterol via nebulizer, you can give it while symptoms persist for as long as your transport is. But if you're going to give that duo neb, which we'll talk about in a little bit, you can only give up to 3. You could start with 3 duo nebs and then move on to just albuterol. You could do albuterol, 1 nebulizer, duo neb, a couple of albuterol, 1 duo neb, a couple of albuterol, whatever it is, but total up to 3 duos. And then side effects here similar to epi, because it is affecting that sympathetic nervous system. They're going to have increased heart rate, might feel anxious, and you might see some tremors. So bromide, ipratropium bromide, or Atrovent, that is the second medication that is, oh, it makes up the name duoneb. So it would just be a single mono neb if this wasn't in there. So this is that medication that just, it really dries up the secretions. So if somebody's having wheezing, but you can also hear that there's some liquid in there, maybe they have like a productive cough. You can hear that liquid when they breathe in. That means they could probably use a duoneb. They need those bronchioles opened, and they also need to get some of that fluid out of there. So contraindications, it only goes with a duoneb, so there has to be bronchospasms with wet sounds. And if they're allergic to it, then we don't want to do that. I'm reading the question. Hold on, Connor. If a person is a known heroin user and is unconscious and you don't know anything about their respirations, written test scenario, would you administer naloxone? No, because if they didn't tell me about their respirations, it wouldn't be a good test question. If they were just trying to, if they were like, oh, you respond to a known heroin user who's unconscious, what would you do? The first thing I'm going to say is not administer Narcan. I'm going to say scene safety BSI. I'm going to check their responsiveness. I'm going to open their airway, and then I'm going to assess for their respirations. If they're doing that, that's not a good test question because they're just trying to get you to assume. No, if they're going to ask you to give a medication, they should give you enough information for you to determine that it's indicated. So somebody who's a known heroin addict who's unconscious, that does not mean they need Narcan. That means we need to do a further assessment. That helped, Connor? I'm just hoping that you wouldn't get a question like that. Yeah. Okay, so dose, it is 0.5 milligrams, but we add that into our 2 milligrams of albuterol. So totally, we're just giving 3 milligrams of medication, and it should be around 3 mLs too. Inhalation through the nebulizer. It's an anticholinergic or a parasympathothic. Parasympathothic, yeah. And it just reduces secretions in the lungs. So again, good news for you guys. It's not going to be on national registry. You're not going to get tested on this. So you don't need to know all that. And for the most part, we're not going to really focus on you knowing all the actions and all that kind of stuff for this medication. Really just know your albuterol and the other good ones for that we have on that kind of sheet. Side effects, dizziness, nausea. And these are some nebulizer looking things. So usually you could give it through a T-tube or you can give it through a mask. Just kind of depends on the patient. Some people, especially if they're having wheezing and difficulty breathing, don't like that mask on their face, makes it feel worse. They'd much rather like use it when they feel comfortable. So whatever they like, you can use. And I think a lot of services are packing these now, which is just one little Kool-Aid wax tip thing that you squeeze out, which has both the albuterol and the Atrovent in it. It is a duo neb packet if it's got this blue and purple on it. And it should be just albuterol if it's just a blue package. And we can only do this for adults. Sorry, so they have to be over 18 to get a duo neb. Not for any fun reason or anything. Okay, how's everyone doing? The last thing I was going to talk about here is do that kind of quick review of some CPR kind of stuff. Does anyone have any questions? Doing okay, we'll power through. Excellent. So when we're using an AED, it's assessing for two rhythms. It's assessing for VFib or VTAC. So essentially VFib, the heart's electricity is sporadic and it's all twitchy. And if it's VTAC, it's just too fast for any blood to get in and get squished out by the heart. So this is what they look like in the heart. The heart with VFib, you can see it's just twitching, not actually doing any meaningful movement. And then with VTAC, the ventricles, that bottom part, those two big, what's the word? It's, thing, the heart thing, the two big parts are squeezing too fast to allow oxygen in. Don't look at me. It's fine.
Ventricle.
All right. So, yes. No, I know ventricle is. It's such a simple word, guys. It's just one of those times. It's right on the tip of my tongue. I want to say school, but
Lobes?
that's not it. Lobe, close. Chamber. Yeah, who said that? What? Yeah, Pat, you got it. Thank you. So look at this straight line, relatively straight, squiggly. There, you have just interpreted asystole, no electrical heart activity going through the heart. That is what we can determine off an EKG. So if you see that on an EKG, you can say, wow, they're dead. Done. Walk away. So that's the only thing we can really do. It just tells us they're dead. That's bad, right? Start CPR if you see that. So we're determining if they need CPR, if they are unresponsive, if they don't have a pulse and they're not breathing. If they're pulseless and a medical cardiac arrest, or there's no way that we can say that they were put into cardiac arrest by a traumatic injury, that's when we're going to start CPR. But if they are put into cardiac arrest by trauma, that's when we will not. Or if they have an injury that is incompatible with life, that is when we will not. So if they are decomposing, if you see mushrooms growing on them, if their head is across the room, or and their body is not, or they're internally decapitated, that is a sign incompatible with life. If they have been burnt to a crisp, they're not coming back. If they have rigor mortis, so the rigidity of bones post-death, that just tells us that they are been dead for too long for CPR to work. And then same thing with lividity. If we see a pooling, like a big bruise at the lowest part of their body where gravity is, that's pretty bad. Went to an apartment for a welfare check. Somebody hadn't been heard from in a couple of days. The manager let us in. We found somebody laying prone in their living room, and we went to roll him over, and he was literally stiff as a board, completely flat on his face, and Barney purple. So he'd fallen on his face. He had died. Essentially, all the blood pooled, made him purple. And when we lifted him, the rigor mortis left his face like completely, you could see the imprint of the floor. So like, and he was stiff as a board. So right away we said, nothing we can do. We're going to call a medical examiner, the police. This is a crime scene technically now, and we'll write a report. That happens. And then in Vermont, our purposes here are blunt or penetrating trauma. This is likely going to change a little bit. I actually didn't register if it did change in in the thing I showed you, so I'll look at that again later. But blunt or penetrating trauma, if that caused the cardiac arrest, likely not going to help. With somebody who has a bunch of holes in them, like if somebody has been killed by like gunshots and you do CPR on them, if you haven't packed and closed all those gunshot wounds, every time you compress on the chest, you will likely see a little bit of blood coming right out of those holes. So it's not going to work very well. So say that CPR is indicated, we're going to do call for ALS. They can do a lot more things than we can do. And just more hands in general is going to help. If you are by yourself or you have another person, only call for help. You will need help to work this cardiac arrest. And then just begin CPR protocols. So for our purposes, that means starting compressions, and we're going to do high performance CPR in Vermont. So you're going to emphasize just compressions, reducing the amount of time off the chest, and you're only going to start worrying about airway once you have some more people. Apply that AED in the correct position. So one on the right kind of chest here, and then one on the left flank. We want to do it on bare skin. And when we turn it on, it should analyze and tell us if a shock is advised. Again, this can be dangerous if we don't use it correctly. So we want to stay away from water. Snow is okay to shock people on. We want to avoid shocking directly over medical patches. And if we see them, remove them with a gloved hand, wipe away the residue with a towel or something that could go boom, especially if it's nitro. Just stay away from shocking people on conductive floors like metal. Stay away from shocking pacemakers or internal defibrillators. We can't remove these, and we definitely want to shock somebody if they're in cardiac arrest who has these. So don't put the pad directly over it. Just adjust the pad's position so it's not straight over one of these devices. Or you could look like that. And again, guys, I'm sorry, I had to include a picture of myself. You know how it goes. Someone's super hairy, shave a spot or rip off the pads and put them back on to clear a spot so that you can actually get the pads stuck to their chest. If you don't, and I have seen this, if you hit shock, you will set their chest on fire and then you'd never get the smell of burnt hair out of your nose. It's gross. And you look like that. So I would much rather look like that waking up in the hospital with holes in my chest hair than not wake up at all, right? So rip off my hair if I'm in cardiac arrest. I don't care. So when we're going to analyze, right, the AED will tell us analyzing heart rhythm, don't touch the patient. So we step off. That's one of the only times we'll stop those compressions, and we will tell us, or we will wait for it to tell us what to do. If it says shock advised, we give it. If it says no shock advised, we don't. And then we're going to jump right back into CPR as soon as it tells us. So if it says shock advised, what we do now with high performance is we do a priming of 30 more compressions, and then we work with our team so that they can hit shock as I'm coming up off the chest and then come right back down on. If it says no shock advised, as soon as it says that, just jump right back into your CPR protocol. We did talk about this a little bit, right? So we're going to stay on scene until 3 shocks total, 3 consecutive no shocks, or a pulse returns. After one of those things happens, we're either going to transport or stay on scene to cancel. And if we decide to transport, we'll keep our efforts going in the ambulance until we get to the hospital and pass it off. It's actually kind of interesting, like working a code at the hospital, depending on when it is, you have a lot of people to help. Like you bring somebody in and it's when they've got the medical students in rotation. And so they just have them line up. And every 2 minutes, they're like, all right, next student on the chest, start doing compressions. And while the doctors and nurses and techs work, and then the medical students are just doing compressions and they circle them out. It's pretty cool. So I don't really want to talk about STEMI alert. That's just what we talked about a little bit earlier. If you see the EKG say STEMI, just call and send it to the hospital, say they've got a STEMI. For termination of resuscitation, it's if nothing changes, you don't get any shocks whatsoever, only 3 consecutive no shocks, no difference in any of their vital signs. That's when we would do 20 minutes of CPR And then if all of that stuff doesn't work, we just give a call to the hospital, speak to a doctor about cancellation. But then that's, if we go about that tour process, that's what I say is that we are now taking on the responsibility to talk to the family. So we have taken the responsibility to try to bring them back. But if we're going to consider tour, and we likely will, we also need to register that if we're going to stop resuscitation efforts, we have to be able to defend ourselves to the family. And while we would like to expect that most family members in these situations will be understanding of us, know that we can only do so much, know that we can only, go by our protocols, it doesn't happen like that all the time. There are plenty of situations where family members get aggressive or pretty upset or angry with EMS providers when their family member wasn't able to be revived. So it is a responsibility of ours to keep that in mind. We do need to tell them what happened. And we do need to tell them what we did. And if you take anything away from this, if you're going to tell somebody that their family member is dead, you have to say that. You have to say they are dead, they died, they were killed. You have to give them a true word. If you say they're in a better place now, if you say they've passed on, you're not giving them the full truth. And that can actually lead to major psychological issues. If you're not giving somebody the sense of closure or the truth of what happened, there's a chance it could really affect them. If you told them they're in a better place, they could sue you for saying the wrong thing. Like, there are plenty of instances here. We got to be true. We got to be honest. We got to tell them the hard stuff, even if it's hard to say. So here's what I try to say. If you want to read it, I've read it to you guys already. I've done this quite a few times. It is never fun. A majority of the patients or the family members I've had this conversation with were good about it, but plenty of times they weren't. Went up to the granddaughter, or who, I don't remember exactly if that was. I was just telling her what happened. Essentially started screaming at me and all this kind of stuff. Said, yeah, I'm really sorry, and just walked away. So you can only do what you can say, essentially. But if you have the best intentions behind it and you know why you're doing it, that's what you can do. And that is all I had. So if you guys have any